Dr. Sheila ma'am. Dr. Chalimila ma'am.
Sneha will start. No, Sneha, you'll start.
Yeah, I think Nilima will introduce Charmila.
Dr. Charmila, you are muted.
No, sir, I'm unmuted only, but Sneha, you start the program.
Yes, yes.
Thank
Okay,
you.
no problem. So, yes, no problem. A very good afternoon to one and all. Welcome. My respect and regards to all the seniors and dear fellow Foxians for this ICUG online certificate course on emergency obstetrics. A warm welcome to our respected President Foxy, Dr. Jaideep Tank. I think sir is yet to join. Secretary General, Madam Dr. Madhuri Patel, for accepting to grace the program as chief guest and guide us. ICUG chairpersons, respected Dr. Parul Kotharavala and Secretary Dr. Sarita Balerao, and the course convener Dr. Charmila for giving us this opportunity to organize this much needed program, which can really make our practicing obstetrics not only aware but also well versed with how to tackle the emergencies. Gratitude to Madam Nirja Batla and our dear friend Dr. Bhaskar Pal for accepting the invitation and to grace the program. To share their words of wisdom. Friends, all of you know that hypertension, hemorrhage, and sepsis, these are the three major killers of our women. And of course, anemia being the direct as well as indirect cause of maternal mortality. Right from early pregnancy, we have tried to cover the emergencies, including ruptured ectopic pregnancy. Professor Dr. Kasturi Donimat is going to speak on from Hubli, Dharwad. Everything about justices, the team, Madam Suchitra Pandit, past president of Foxy, Professor Girija Wagh, Dr. Gorak Mandrukar, and of course the seizure disorders other than eclampsia by Professor Murlidhar Pai. We have a team dealing with critical care day in and day out, whose guidelines and recommendations we follow as the benchmark. Professor Manju Puri from Lady Hardinge Medical College, Delhi, Professor Achala Batra, Professor Josna Suri from Safdarjung, and Professor Aparna Sharma from AIIMS Delhi. Dr. Alpesh Gandhi, the master himself, who has formulated this SDU, ICU guidelines for Government of India. So we have the best of chairpersons, including Archana Verma, Sampit Kumari, and Kalyan Barmade, Bhageshri Naik, Anita Rajoria, Sujit Khonkar, Dr. Subhash Malya, Sampit Kumari, Dr. Bharti Maheshwari, Dr. P. Mumtaz, and Dr. Brajwala Tiwari. I'm sure they're going to analyze and compile the subject. Thanks to all of you for accepting the invitation to spread knowledge. All of you know this, but I just inform pretest is for 10 minutes. Immediately before the session, you have 30 MCQs. You have to attend the whole session and also give the post-test. 50% of the correct answers is the criteria for certification. So thank you once again, all of you, for having this program and giving us the opportunity. Thank you so much, and over to you, Nilima. I am for the invocation video. Hello. Hello. Hello, Nilima.
Yes, madam, we are doing.
Please play the invocation video. And the
नीलिमा मैम ऑडियो ऐकू येत नाहीये.
Yes, that is what I'm trying to tell you. We can just pray God and go ahead, I think.
Continue, Sneha.
Yes. So with this, I pray God Ganesha and Ma Saraswati, and we declare that the inauguration has been done with the hands of the stalwarts. And now I hand over the forum to Dr. Charmila Iyer, who is the series convener for this ICOG, and Charmila is the vice president of Foxy, and she was a chairperson for clinical research committee.
So, okay, Nilima, thank you so
I
much.
hand over to you, Dr. Charmila, for the further proceedings.
Thank you so much, Sneha. I will start with the program because I think we're already running late. It's going to be the certificate course on emergency obstetrics. My request the chairperson of ICOG, Dr. Parul Kotadwala, sir, to say a few words before we start the program. Sir, Parul, sir.
Thank you. Yes, I'm here. Am I audible?
Yes, sir. You're audible, sir. Yes, sir.
Thank you. Well, this is number 2 session in the series, and I compliment Dr. Sneha for working on this with a detailed program. And as the first program which went very well on PPH by Dr. Sheila, I'm sure that this one will be also greatly appreciated by our members. Couple of doctors, in fact, from Gujarat called upon me that we are not getting the link or regular information. So I do not know. I believe that Nilima, we do write to Foxy, right? That the link is shared through Foxy or not?
Yes, sir.
Nilima?
Yes, sir. My actually connection was gone. sir.
Because
Yeah.
a couple of them did call me up. So in future, see to it that every member get the link of the program, and if possible, we can pass it on to Foxy as well.
Yes, we
Isn't it?
sent. Yeah. Yes.
So it comes to all of us, sir. They have to check their mails actually. It comes regularly.
So already, so maybe they have to check their phone number or mail.
Yeah, yes, sir.
But I'm
something
sure that this one also will be a very successful program. I am already seeing the number 318, and it is getting on and on. So I wish you all. Oh, there is the 900 registrations till now, but 318 are online actually. And I do see Dr. Madhuri here, Dr. Parag. So let us all get on with the program rather than spending time on formalities. Charmila, you can.
Yes, sir. Thank you so much, sir. Thank you so much for those words. Now we go on to the academic session. Before that, we have the address by the chief guest. I think Dr. Jaideep has not joined. My request, Dr. Madhuri Patel, Madam, the Secretary General of Foxy, to say a few words before we go on to the program.
Charmila, can you hear me?
Yes, ma'am. You're audible. Yes.
Okay, I'll just increase the speak now. Hello?
Yes,
Better?
ma'am. Yes, ma'am.
Better.
Yes.
So good evening to all of you. Our chief guest, Dr. Jaideep Tang, I think he is not well today, so that's why the reason he may not be joining today. And our ICOG most dynamic, ICOG chair, Dr. Parul Kotrawala, then Dr. Sarita as an secretary of ICOG, series convener Dr. Sheila Mane, Dr. Parag Biniwala, Dr. Charmila, convener Dr. Sneha Bhuar, coordinator Dr. Monica, Dr. Supriya and another Monica, and all my dear friends. I can see so many friends of mine, Supriya, Brijwala, Bhagya Lakshmi, every Nirja also I saw, Bharti also, Meena, so many people I've seen, and very good evening to all of you. This obstetric emergency is really, we always say it is adrenaline surge for obstetrician. we have, dealt with so many obstetric emergencies because it is a life-threatening condition, not only to the mother, also to the baby. And if they survive from that, then naturally the morbidity is very high. So as an obstetrician, we should anticipate with a little, abnormality, we should anticipate that they will end up with certain emergencies, and we have to deal always. Have to be on our toes to deal with it. And today's topic, there are so many good topics. This certificate course that Dr. Parul has started with the ICOG certificate course for 3 days. This is really going to help all our obstetricians. And it is really going to matter because with this we can reduce the maternal and perinatal morbidity and mortality. So updating the subject is very, very important. And our Indian College of Obstetrician and Gynecologists are doing excellent job. And today's topic, rupture ectopic, hypertensive crisis, and so on. And we have a great, speakers. They are the teacher, academician, and we are going to learn so many things from that. I am not going in detail about the topics and speakers, but when I went through it, they are really great speaker and they are really going to teach us. They are going to give us insight, which will be definitely practicing to reduce, as I mentioned, maternal mortality, morbidity, and perinatal mortality, morbidity. With this, I am, not going to take much time, but I congratulate ICOG team and all the conveners, co-convener for and the speakers and the chairperson for the most apt certificate course, which is going to happen for 3 days. And I wish them best luck for, I always forget Bhaskar. Bhaskar, please excuse me. So now I'm saying hello to Bhaskar. So I wish all of you best luck for this course. Thank you once again for giving me this opportunity.
Thank you. Thank you so much, ma'am.
Thank
Now
you.
we go on to the program. We have got two eminent people as guests of honor, Dr. Neerja Batla, the Vice President of Foxy, as well as Dr. Bhaskar Pal, the past Vice President of Foxy. May I request Dr. Neerja Batla to say a few words as guest of honor.
Thank you
And-
very much, dear Charmila. Thank you for inviting me here today. And good evening to all our dignitaries here. I'm sorry to hear that Dr. Jaideep is not well. I hope he gets well soon. Dr. Madhuri, wonderful to see you. Charmila, my dynamic co-vice president, and many other dignitaries I'm seeing. I see Dr. Sheila Mane is also back, Dr. Parag, Dr. Parul, of course, our ICOD. He's there, but I'm not seeing, and Bhaskar is back as well. So it's really nice. And what has been said about the obstetric emergencies is definitely very relevant, that this is something we have to be able to manage within minutes or seconds even. This is something I've said to generations of students, that you may get away with not knowing, because none of us knows everything. None of us knows everything. So long as you can demonstrate that you have a logical approach and the ability to access and process information correctly, you can get away with not knowing many advances. But you cannot get away with not knowing management of an emergency. Because at that time when patient comes, there is no time to go and consult the book or even your phone or to ask anybody. You must know these things on tips of your fingers and be able to do the needful. So these are very, very important. I really compliment Dr. Sneha. Thank you, Sneha, for inviting me here today and for the wonderful work you are doing to conceptualize these courses. All of you, it's not the work of one person. I know how many people go into, but I think it's a very, very useful task, and all our members will find it useful, informative, of day-to-day importance, and it will be of much benefit to mother and child. What has been said is very right. For every mortality, there may be 10 others like tip of iceberg. There will be the severe morbidity. There will be near miss cases. And these have a huge impact on the family, but also on our society, on our economy, everything. So by mastering obstetric emergencies, you are really making a difference. So thank you very much, and my best wishes.
Thank you so much, Dr. Neerja. May I request Dr. Bhaskar Pal to say a few words, sir?
Yeah, thank you, Charmila. As much as I'm pleased and honored to be here, I think we need to be quick and we need to, I think, reduce our guest culture a little bit, because there are 400 people patiently waiting, and I can see people's eagerness to do the pre-test as soon as possible. So I congratulate the entire ICOG team of Dr. Parul, Dr. Sheila, Dr. Parag, and Dr. Sarita, and in particular, Dr. Charmila and Sneha. Great to be among friends. I can see Archana, I can see the Madhuri, I can see Nija, I can see Supriya, Monica, but I wish this is a great initiative, and I think this will help people. And I'm actually excited to see 400 people coming in for an emergency obstetric certification course. That people still think obstetrics and not only IVF and endoscopy. Great, and I wish you all the best, and thank you for inviting.
Thank you so much, sir. After that introductory section, we are going to the academic session. As a preamble has already been done by Sneha along with the introduction. We'll go on to the pre-test, and the pre-test will be there for 10 minutes. A timer will be on, and it will be on the screen also. And there are 30 questions you need to answer. And even if you're not able to answer the full pre-test, don't bother, because the post-test is most important. And that will be at the end of the day. And you have to answer them again. A 50% score every day will set you a certificate by ICOG. And you need to attend on all 3 days to get the certificate, and that's compulsory. May we go on to the pre-test? Can I ask Neelima to put the link for the pre-test and the timer also?
Yes, yes. Gauri, please do the needful.
the pre-test is over. We'll go on to the academic sessions. The coordinators for all the 3 days are Dr. Monica Singh, a very, very sincere Foxy member from Bhopal, Dr. Supriya Jaiswal, the chairperson of the Adolescent Health Committee, and Dr. Monica, the coordinator for the Public Awareness Committee. May I request the coordinators to take over. And there are some complaints regarding that the mail doesn't reach them. Please send a mail to ICOG office. You will be sent the regarding the courses for the future months to your mail. Please make sure that you send a mail to ICOG office saying that you have not received the message regarding the certificate courses. So we'll go on to the academic session. May I request the coordinator for the day to take over, please? Thank you so much.
Yes, Dr.
Thank you,
Monica.
Chair. Yes, ma'am.
Yeah.
Thank you, Charmila Madam and Sneha Ma'am. We declare that the inauguration is over now, and I would move forward for the next academic session. Our chairpersons for the first session today, Dr. Archana Verma Madam. Archana Verma Madam is a Vice President-elect Foxy 21. She's also the founder president member of the West UP chapter, the organizing chairperson of the UPCOG 2020. She has many accolades to her credit. We welcome you, ma'am, as a chairperson for this session. Our next chairperson is Dr. Kalyan Baramde, sir. He is the secretary of IAGE for the year 23-24 and has been the chairperson of the Infertility Committee AMOX and the past chairperson of the Public Awareness Committee. We welcome you, sir. Our chairperson for the first session is also Dr. Bhagyalakshmi Nayak, madam. She is the HOD at the Department of Gynecological Oncology at the Cuttack Medical College, and she has been the chairperson of Oncology Committee Foxy, and she is also a governing council member of ICOG and the vice president of AOG in India. We welcome you, ma'am. Our chairperson for today's session, Dr. Anita Rajodia, madam. She is the head of the department and senior consultant at the Dr. Hedgewar Arogya Sansthan, Government of NCT, New Delhi. She is also a part of the Asian and Oceania Gynecological. Her major
Thank you, yeah. Thank you, Monica. Thank you, Sneha ma'am also.
And chairperson for the first session also is Dr. Sujit Kotkar, sir. He is a fetal medicine consultant from Aurangabad Obstetrics Society and is currently the chairperson of the AMOX Fetal Medicine Committee. I welcome all the chairpersons for the session today, and I would like Dr. Archana Verma, madam, to introduce Dr. Gorak Mandrupkar, sir, for the first session. Dr. Kasturi, madam, will be speaking for the second talk.
I welcome
Over
Dr.
to you, Archana, ma'am.
Gorak
Yes,
Mandrupkar. He is a favorite of. I must say that one person who has done wonderful work in the Foxy also and Amox also and everywhere, favorite of all. What to say about him? I think great welcome to Dr. Gorak Mandrupkar. You take and you can say your talk. I think few words are more than enough for a great person. He is the best.
Thank you so much, madam, for those kind words. And I'm very much thankful to Dr. Sneha Buyar, madam, Dr. Charmila, and ICOG, especially Dr. Parul Kotlawala, Dr. Parag Beniwale, sir, for inviting me in this prestigious session. The course, which is on emergency obstetrics, and everybody knows that still, hypertensive disorders of the pregnancy is a nightmare. And recently only, in one corner of Maharashtra, we conducted a very beautiful workshop and even a survey. And there, the maternal mortality rate, when we gone into the depth, in the detail, we found out that almost 70% of the maternal mortality of that year was because of hypertensive disorders of pregnancy. So that means, though we are saying that eclampsia is reducing day by day, but still the hypertensive disorders of the pregnancy still remains a challenge. The very important factor, the late marriages, the obesity, then increasing artificial reproductive technology techniques, then the PCOS, and many things. They all are leading to the increase in the number of hypertensive disease patients. So it is a need that we must look towards this topic, revisit again and again. And so I'm thankful to the organizers that yes, they chose this topic about the prediction and prevention. See, this is very important, and I will be going in next 15 minutes about this topic in very much details. We all know that in India, we are doing 26 million deliveries per year, and the incidence still it is 10.3% of hypertensive disorders. That means we all the gynecologists, obstetricians across the country deal with 2.7 million cases of hypertensive disorders. Though the incidence of eclampsia has gone down, still it is 1.9 to 2%. That means 0.5 million cases per year. And WHO has, yes, agreed yet, and I gave an example also. But yes, overall statistics of India, 19% of the maternal deaths are again still due to hypertension in pregnancy. So we all agree that there is definitely need for early and universal screening. Purposefully, though I started my talk with the slide prediction and prevention, I am using word here as early and universal screening. I think we all should use this word. And in spite of saying prediction, we all should say universal screening, because once we say that, then it becomes our moral responsibility that yes, each and every patient should be screened for hypertensive disorders of pregnancy. But it is very gigantic task. As I said, we are dealing with 26 million of the pregnant women. So then, going back to the subject of the preventive medicine or the community medicine, we all know that what is the ideal screening test, which is easily reproducible, validated, then it should be authentic, then simple. So if we follow all these criteria, then there is a problem. None of the tests, single test is there which will follow all these criteria. There are almost more than 60 tests they are suggested. And it was really a dangerous job when we were postgraduates to remember all of these. If we classify them, so depending upon the placental perfusion and vascular resistance dysfunction, in all these tests like rollover, Doppler, isometric exercise, and whatnot, depending upon the fetoplacental unit dysfunction, alpha fetoprotein, activin, PAPE, all these tests they were suggested. Then uric acid, urinary calcium, then depending upon endothelial and oxidant stress dysfunction, all of these tests. So all of, if you see, there are more than 60 tests, but none of the tests is bound to be reliable as a single test. And that's why all the guidelines, right from Western, Eastern, Middle East, WHO, everybody has come to the conclusion that the prediction or the screening based on assessment of clinical risk factors is recommended. So let it be our FOXY, our own FOXY, ICOG, justosis, good clinical practice recommendations. If you see United States Preventive Service Task Force guidelines, Australian guidelines, even NICE guidelines, or very recent WHO guidelines, everybody is saying that clinical risk factor based screening is recommended. One or two organizations, small, they are saying that maybe the other, but yes, everybody has come to the conclusion that clinical risk factor based screening is recommended. In between this stirred a lot. There was this trial, but this was not actually a trial. Actually, it was a regression analysis. And this stirred a lot. They showed, yes, the method of screening, if they use combine, when they combine the PLGF, PAPE, along with uterine artery PI, along with mean arterial pressure, along with maternal factors, then yes, the detection rate has gone to 81% of early preeclampsia. And regarding the late preeclampsia, it went up to 43%. Fine. This is a good analysis, no doubt about it. I'm not against, or nobody is against the biomarkers. Nobody is against the Doppler. Nobody is against combining them. My question is, can it be a routine screening tool? Answer is no, because it is impracticable to apply to every pregnant woman in general population. America, in his or ACOG, in its guidelines, it has said that it is not possible for America to do such a costly test. If they are saying that, what about us? Still, I did an experiment, and when we calculated the budget was 2,800 crore per year, which was 1/10 of the total allocation to National Health Mission funds. So it was not possible just to think to do all these tests. And then a thought came, can we simplify the screening? The answer is yes. And this is how the HDP justice score has come. What is it? It is a simplified, dynamic, feasible quantification of the maternal clinical risk factors for effective screening of the hypertensive disorders of pregnancy. Each word has importance. In the words of Padma Vibhushan, Dr. Raghunath Mashelkar sir, he has said this as innovation. It is an affordable Indian innovation because it is of no cost. Because whatever factors we have considered for the Indian population, day to day, whenever we see the ANC, antenatal care patient, BC, thyroid, GCT, and what parameters what we see about the patient or the history what we take, depending upon that, the score was developed. Fortunately, I initiated this idea, which was modified by Dr. Sanjay Gupta, Dr. Suchitra Pandit, Dr. Alpesh Gandhi, Dr. Girija Wagh, and it was accepted in the FOXI ICOG Justice GCPR 2019. And now I'm very proud to say that it is validated. 68 theses are being conducted on it, which have shown that sensitivity and specificity, almost in each case, each study, more than 90%. There are 4 international papers on it, which are being published by other research workers. Let us see how we have developed it. We have gone to the mild risk factors, moderate risk factors, and high risk factors. You all know, even ACOG, RCOG, NICE guidelines, they have given some maternal risk factors depending upon their population. Maybe there are some 12, there are 13, 14 in ACOG. From our Indian population point of view, we recognized 27 clinical risk factors. Then we have gone into the depth and we have seen, suppose a single factor is present, and then it makes that woman to be very high risk to develop preeclampsia. We have labeled it as high risk factor, and we have given the quantification as 3. When it was seen that if there is a combination of 2 factors, and then that lady becomes more than high risk, at risk to develop the preeclampsia, such factors they were given label as a moderate risk factors, and the quantification was given them as 2. And when 3 or more factors, they combine together, and then they increase the risk of that lady to become high risk to develop preeclampsia. These are the mild risk factors. And they were given quantification as 1. When we hear, there are 27 risk factors, everybody or many of them, they ask, it is our job, because when we were learning the medicine, we were being told to take a deep and detailed history. And I think whenever we sit with a pregnant lady at first visit, definitely all of you, we take a detailed history. And what is that? See, age older than 35, less than 19, anemia, obesity, BMI more than 30, priming, short duration of paternity, women born as small for gestational age, PCOS. If she is second or multigravida, then interpregnancy interval more than 5 years. If she is conceived with IVF ICSI with her and husband's gametes, MAP more than 85, dyslipidemia or excessive weight gain during pregnancy. All these are considered as mild risk factors. We have gone into the depth, so many studies, and then this was designed. Now it is validated. Moderate risk factors, everybody will agree. When we talk of hypothyroidism, GDM, then we say, yeah, these ladies are at risk to develop preeclampsia. Yes, these are the moderate risk factors. Even HTP during previous pregnancy, multiple pregnancy, it is a moderate risk factors. And these are the high risk factors where presence of single factor, it will lead that woman to be at risk to develop preeclampsia, and they are known case of diabetes, chronic hypertension, mental disorder. There is a lot of references which have shown that the mental disorder which requires a treatment is very high risk. That lady is very high risk to develop preeclampsia. Inherited or acquired thrombophilias, autoimmune diseases, CKD, and here again comes the ART, but here with OD or surrogacy that takes the lady to very high risk from minimal risk to high risk. Now see, if we see again these questions again and again, these are the routine things what we ask to them, and these are the routine investigations what we do. Then somebody asked me regarding the dyslipidemia or regarding this hypertensive disease in previous pregnancy or family history. Yes, they come on history basis. There is no need to check each and every family member, but that lady definitely knows that she has the first or second degree relatives which are with all these histories. And that had made our population to be at high risk. See, forget about all those Western people and their guidelines. We are 11 times high risk. Indian population, 11 times high risk than the Caucasian population for these diabetes, metabolic syndrome, and hypertensive disorders. And that's why we are capital of diabetes now. So we all should look into these factors. Then there are certain factors which are dynamic, like anemia, because we are seeing in each trimester. GCT we are doing in each trimester. TSH we are doing in this trimester. MAP will be variable, and lastly will be the excessive weight gain. So except these 5 factors, rest all 22 factors we come across at the first visit itself on the history. If she doesn't know many of the things, she can go and inquire at home. Nothing is problematic. Our motto is, if we take all these history points as early as possible, before 8 weeks, and if we start the preventive strategy, there will not be the preeclampsia or the very, very minimal preeclampsia, because we all know that the defective trophoblastic invasion, that is the main cause for this preeclampsia. And when the first wave of the trophoblastic invasion comes, as early as 6 to 8 weeks, and then at the initiation of the second trimester, it completes. And if we do all those investigations as per the Western guidelines at 12 to 14 weeks, and then if we start the preventive strategy, how are we going to prevent the disease? How are we going to reverse the pathophysiology? That we are not understanding. And that's why it is a sincere request that please do this. Now there is an app available, which is free of cost. Please go on Android App Store. It is not available on Apple, Google, Apple, available on Android App Store. Free of cost download, and you can do this within 1 minute. We are calling it as a 1 minute. We have done a survey of 2,000 doctors, and depending upon that, we have seen that yes, a doctor can complete this within 1 minute. Last few slides, 2 or 3 slides. Prevention, yes. Aspirin 75 milligram at the bedtime, along with elemental calcium 1 to 1.5 gram in divided doses. Low carbohydrate and high protein diet. No need of salt restriction, but no excess salt. I'm not going in details, but a very important line. Why 75? Because WHO says 75. All guidelines say 75. If anybody has done the biomarker screening by their protocol, only in those cases now they are saying 150 milligram. But there is no single study which have compared and said that 75 is not sufficient and 150 is required. There is no single study on this earth. Another thing, the man who has done a lot of research in that, Dr. Baha M. Sibai, has given a beautiful study and he has shown that 40 to 60 milligram per day is sufficient, more than sufficient, because what this low dose of the aspirin does, it prevents or it does the very good balance between the prostacyclin and thromboxane A2. If the dose is increased, there is imbalance again. So it is better that 75 milligram at bedtime, daily till 2 days prior induction or delivery is the best option. Don't worry about the 75 milligram during the threatened abortion. Don't worry that 75 milligram is not going to cause any problem in platelets. Last, there are clinical evidences. Each clinical risk factor has good quality evidence. I'm not going in detail, just giving one study, which again has given very beautifully that clinical risk factors in that population, they are to be studied. And this meta-analysis includes 92 studies. And can you see the patients which are involved? There are 2 crore 53 lakh 56,688 in 27 countries. And that BMJ analysis has even shown that the clinical risk factors we have to give importance. This is an app and Jammu study. We started right from Jammu to Kanyakumari and from Ahmedabad to Pragjyotishpur, that is Guwahati. And everywhere we have done the study. Sensitivity here was 83%, specificity 97%. Published study, and Dr. Meeta, my sister, she got award for that. Another was in BJOG, Kolhapur. They shown sensitivity and specificity more than 95%. Visakhapatnam study, they show it as a novel early marker. And then this was a very beautiful study which was done by the Symbiosis, where they compared and they thought whether this method of doing justice score is right or wrong. Right? And what they did, machine learning algorithm and justice score, they actually did this study and they come out with the fact that this is very recent. It was accepted in 10 February 23. And I'm very proud to say, yesterday again a big study on this machine learning tool and its comparison with the justice score. It is accepted. It will soon publish in the international journal, and that has shown that it is a simple scale that can be administered by all frontline health workers in community without intrusive procedures. Our simple ASHA worker, ANM, even they can do the scoring system and they can do the prediction of the hypertensive disorders of pregnancy. It is my sincere request, all of you, download the app. If the app is not available, please go on our Foxy or ICOG website. There, these GCPR are available. In that, even you can download one page, just one page, and then we can put it on our ANC paper and we can just put the ticks on it. And definitely, please mark that patient with red pen. She is high risk. Start her aspirin 75. Start her calcium 1 gram. Forget about the low resource setting and all. Whole India is low calcium resource. So we have to give it. And there is no harm in giving excess calcium. Other things, stop the carbohydrate or minimize the carbohydrates. High protein diets. Don't advise bed rest at all. And we have to see the blood pressure of every pregnant woman in sitting position, and especially of these high risk women daily, whatever the in the and we have to predict and prevent these preeclampsia or hypertensive disorders. I thank again for ICOG, all the members who are involved, especially Dr. Sneha Buyar, madam. She has a passion about taking this justice score to every corner of this India. And Dr. Charmila, who has worked, Dr. Parag sir, who has worked very well for this Justosis score. And it is a sincere request. Once again, I thank you all again for patient listening, and I'm open for questions if allowed. Thank you very much.
Thank you, Gorak sir. There are only a few questions. How early should the aspirin be started? And which is the name of the app, sir?
The name of the app is HDP Justosis Score. Android App Store may उपलब्ध है. And we can start aspirin as early as possible. Please mind well, all the IVF consultants sitting here, they will agree that they are starting even from pre-gestational period, and that aspirin doesn't cause any problem but helps. Here I will advise, as soon as the pregnancy is detected, and if that lady is taken with the Justosis cure that, oh, she is at high risk to develop the hypertensive disorders, we have to start along with 1 gram calcium. That is the answer. Over to you.
Thank you so much, sir. I request Kalyan sir to please introduce our next speaker for today, Dr. Kasturi Donimat ma'am.
Yeah, Gorak, excellent presentation. And I would request you to clarify the queries which are there in the chat box, please.
Okay, madam. I will.
Thank you so much.
Thank you.
At the outset, I'd like to thank Team ICOG for this opportunity. Dr. Kasturi is Math is HOD at KIP, President-elect of 2021 Karnataka State OBGY Society, Secretary General of Kasoga, worked as Treasurer of Kasoga, was President of Hubli Dharwad OBGY Society, was Secretary of HDOGS, and co-investigator for National Research Project. Is a faculty at State and contributed to many books. She's going to talk on ruptured ectopic pregnancy. Over to Dr. Kasturi.
Yeah, thank you so much. Pleasant evening to one and all. Thank you, sir, for that nice introduction. And my special thanks to Dr. Sneha, my very good friend, I met her on many occasions, and Dr. Parag and all the whole ICOG team and Dr. Charmila for this opportunity. Today I'll be talking on ruptured ectopic pregnancy. So I'll not go into the details of whole ectopic. Mainly I'll stick on to ruptured ectopic. One second, I'm just adjusting. Okay. So hope my slides are visible.
Yes, yes, Dr. Kasturi.
So, as all of us know, I'll not go into the details of definition. As all of us know, it's implantation outside the main uterine, normal uterine cavity. But most important for us to remember is the most hazardous condition, most serious, and the most important thing in ruptured ectopic pregnancy is timely recognition, high index of suspicion, and aggressive and very prompt intervention. That should be the motto of our treatment in these cases. Okay, my slides is not changing. Okay. So as all of you know the different sites. I'll not go into much details. It's both extrauterine and uterine. So extrauterine, all of us know, tube is the most commonest. Next, abdominal, primary, secondary, ovarian. But one thing just I want to highlight is we always talk extrauterine, but some conditions are there where we have implantation in the in utero also. That is nowadays that is cervical long back we know. But nowadays what one I want to stretch is cesarean scar pregnancies. With the increase in rate of cesarean section and the niche, we are finding more and more cesarean scar pregnancies. So that also high index of suspicion should be there in a previous LSAS case when they come with severe pain, bleeding, or some kind of catastrophe. And angular, corneal, and cervical. So not only extrauterine, some part of uterine. This is a new thing here. Okay. Now, what are the causes? It is the risk factors are mainly, it is more in due to if the patient had history of PID, or history of IUCD insertion. As all of us know, IUCDs will prevent intrauterine pregnancies, but they will not prevent extrauterine pregnancies. And in IUCD also, it is more common in those who have inserted LNG IUCD rather than copper IUCD. And history of tubal surgeries, assisted reproduction, because all this incidence is increasing, we are seeing more and more of cases, especially with increased assisted reproductive techniques, we are seeing more of these cases. So as all of us know, the range, it ranges from 1 in 300 to 1 in 150. So much it is increased. And even the late marriages and late childbearing with the poor quality of the egg, the quality of the egg also matters, which prevents its transmission in utero. So that also can be the cause for ectopic. As I told you, in assisted reproduction, it ranges more than 5%. And recurrence, as we know, after one ectopic, the recurrence is around 50%. But after 2 ectopics, the recurrence jumps to 25%. So the causative factors, if you take mechanical tube, as I told you, if it is a long narrow tube, or if there is some diverticula because of the previous some surgery or some infection, or if the tube has accessory osteo. So all this can be a cause for this thing. And traumatic, if after tubal recanalization or tubal reversal surgery, or if there was some damage tube which are corrected, salpingoplasty, then that can be a cause for ectopic pregnancy. And as all of us know, inflammatory, chronic PIDs, bacterial vaginosis, all these infections can be a cause, tuberculosis, etc. Or any tumor pressing on the tube and affecting the tubal motility, like fibroid, broad ligament tumors, can be a cause. And functional, as and tubal spasm or antiperistral contractions, especially drug-induced sometimes. Endometriosis, yes, that also affects the motility and encourages the embedding of the fertilized ovum in the tube. So whenever you are talking about risk factors, you should ask if there is any history of tubal surgery in the patient, history of infertility, history of sexually transmitted disease in the past, history of any pregnancy after ERT, history of previous ectopic which was managed conservatively. Even if you have used methotrexate, also sometimes the risk is more, but it is more after some salpingotomy or ostomy, or with or without surgery if it was managed conservatively. And if there is contraceptive failure, and IUCD, as I told, it's more with LNG IUCD compared to copper T. Now, what is the pathology? Once there is pregnancy in the tube, what happens next? What happens is initially it percolates into the blood vessels in and around. There will be bleeding. So there is a clot in and around that sac. Then it may remain for some time, but depends on which part of the tube. If it is isthmus, it ruptures faster because it's small, narrow. If it is ampullary, it ruptures little later. So if it is isthmus, it will rupture within 6 weeks. Ampullary, around 7 to 8 weeks, it may rupture. Or sometimes it may stay there for a long time and form chronic ectopic pregnancy. Or very rarely, if it is very early gestation, it can get absorbed by apoptosis and involute, and that is disappearance. Then the next one is tubal abortion. Usually, if it is in the ampulla, it gets separated and it comes out through the fimbria and it gets aborted. So it gets expelled into the peritoneal cavity. So if it gets totally expelled, no problem. But if little bit remains, then it goes on bleeding and there can be hemoperitoneum. Then the blood collects in the pouch of Douglas and then. So, but this bleeding may not be as so much sudden and so much acute as rupture, but still she'll be bleeding. It may take some 1 or 2 days also here, but the patient is little stable initially and later she'll go on deteriorating in tubal abortion. Rarely the sac which has come out may get re-implanted on some abdominal structure and start growing there as secondary abdominal pregnancy. So, as I told you, if bleeding is if it is separation is incomplete, and she may bleed more. And what happens if it doesn't get aborted, and mainly if it is in the isthmus, which is the narrowest portion, then it will rupture. If it ruptures in the antimesenteric border of the tube, usually there will be profuse bleeding, and that bleeding is into the peritoneal cavity, that is intraperitoneal hemorrhage. But in case it ruptures in the mesenteric border, then what will happen? This bleeding will be in between the two layers of the broad ligament, and it will form a tubal, this broad ligament, huge broad ligament hematoma. So if just a picture of tubal abortion, how it looks, it comes out through the femoral end, mainly starts in the ampulla. And if it ruptures, this is a picture of a rupture. And if it ruptures in the mesenteric border, then it can go to form a huge broad ligament hematoma. And very rarely, I told you, it can get reimplanted on the other structures and start growing there as secondary abdominal pregnancy. Now, how to diagnose ruptured ectopic pregnancy? So there is an important triad of this ectopic. One is pain, second is amenorrhea, third is bleeding. So any woman in the reproductive age group, a patient comes with amenorrhea and pain with spotting or bleeding, if this triad, you should have high index of suspicion of rupture. You should rule out ectopic pregnancy in these cases. So what we find is because patients, but all the symptoms are not there in all the patients. Many patients may not have new history of amenorrhea if it is too early. So in 60 to 80% patients, they may tell they had a period of amenorrhea, 1.5 months, 6 weeks, 8 weeks, etc. But some patients we have seen, they won't even give the history of amenorrhea because they would have had some kind of spotting. So they think that is the menstrual cycle and they won't give amenorrhea. So, but here, I told you, any woman in the reproductive age group, if she comes with acute pain, and even if there is no amenorrhea, acute pain, lower abdominal pain especially, and symptoms of fainting, syncopal attack, with or without that, you should make an effort to rule out ectopic pregnancy. So any pain, whether it is sudden, severe, or chronic, acute pain, you should, because pain is the most important symptom in ruptured ectopic pregnancy, that is in 95% of them. And as an amenorrhea. Then vaginal bleeding. It is not always heavy. Scanty brown discharge or spotting there between. Along with this, they will have, because there is blood in the peritoneal cavity, reflex vasomotor disturbances. So symptoms due to that. What will be the symptoms due to reflex vasomotor disturbances? They'll start feeling nausea, vomiting, fainting attack, syncopal attack, all this will be there. So any woman coming, so what is happening is, so many times we see that they just land up in some emergency casualty and the duty doctor sitting there will not know. This patient, other day, just 2 months back also had a patient who had come with just nausea, vomiting and was referred to a physician because of that. Luckily, physician took our opinion, then it turned out to be ruptured ectopic. She had no other symptoms, just she came with acute episode of vomiting and nausea. So they come with various types of symptoms only unless you have that intuition, gut feeling, or this high index of suspicion. So I told any woman in reproductive age group, any symptom. And many times, just as a syncopal attack, fainting attack, they just go to the casualty. So she'll be referred to either neurosurgery, neurophysician. So by the time they come, they investigate, they'll be thinking of some brain this thing. And once we had a patient which she came with shoulder pain. So because of the acute shoulder pain, that patient was referred to orthopedics. And because she was very pale, luckily they referred us first, then it was turned out to be ectopic. And some patients just come like they have a lower abdominal pain and urgent feeling to defecate. That is because collection of blood in the pouch of Douglas, which presses on the rectum, and they have urgent sensation of defecation. And so only we should sensitize not only gynecology, other departments also, that if a patient comes with pain, amenorrhea, with or without amenorrhea, any other symptoms, please take an opinion of OBGYN to rule out ectopic pregnancy. And one more thing is, once you examine, on examination, we find that if it is ruptured and with a heavy bleeding, patient will be restless, she'll be rolling with pain, and she looks so much blanched. There will be no other cause. If you search for bleeding, she'll not be having heavy bleeding per vaginally or any other cause of heavy bleeding. So if she's not bleeding acutely anywhere, active bleeding which is not seen outside anywhere, but she's blanched, she's totally pale, then again it should have a high index of suspicion and rule out ectopic. And she'll be sweating with cold, clammy skin, features of shock, and tachycardia, hypotension. And one more thing is postural. We had some patients postural hypotension. But whenever they used to get up from this thing, the husband brought her like that. So once we were called, patient is not able to get up from this thing, she's having giddiness, but otherwise she's okay. Then we suspected, and it was thought to be we could detect ectopic in her. And per abdomen findings, there will be pain, but pain may not be on one side. It may be unilateral, it may be bilateral, it may be diffuse. So whether unilateral, bilateral, or diffuse depends on how much she has blood inside, how much the blood collection. And abdomen will be tense, tender, mostly in the lower abdomen. And so many times there will be guarding, rigidity, and rebound tenderness. Especially this guarding, rigidity, tenderness, patients go to surgeon thinking that it is appendicitis or appendicular rupture and all. Many times we have been called to the surgery OT after once they open thinking it is appendicectomy, and then it turned out to be ectopic pregnancy. Perspicuum bleeding, very minimal. It is not huge bleeding because just it is a suppression of the decidua. And when you do per vaginal examination, first, as soon as we do bimanual examination, first thing we see is cervical movements. We ask the patient whether she has pain on movements of the cervix. If cervical movements are tender, you should have high index of suspicion. And then size of the uterus. Uterus size may be normal or bulky, or sometimes uterus may be in the center, sometimes deviated to the other side if there is a huge broad ligament hematoma. And fornical tenderness. I told you, all the symptoms are not there in all patients, but even if you have one, then you should investigate for that. And as I told you, always think and have a gut feeling for this ectopic pregnancy. Then only you can save those patients. What investigations you will do? Serum beta HCG. Yes, urine pregnancy test. If she's more, sometimes it may come for negative very early if she has not missed the period. So in those cases, beta HCG is very, very sensitive. It helps. So we should be more open to doing beta HCG in all these cases so that we can detect them. We will not miss any of these cases. So negative urine pregnancy test does not rule out ectopic pregnancy, but if you do beta HCG, a very high index of, you can detect most of the cases, almost all the cases. And even in beta HCG, if you are doubtful, means after doing the scan, you are not seeing anything, then you can repeat this beta HCG after 48 hours. That is, after 48 hours, if there is doubling, it is normal pregnancy within the 42 days of gestation. And if there is lower concentration, but not doubled, then you can think of ectopic pregnancy. But if the beta HCG is reducing than the previous one, then it is a failed pregnancy. Then ultrasonography, it's highly sensitive. So both transabdominal and transvaginal, but most of the thing is transvaginal. Means you can combine both, but transvaginal is a must ultrasound to detect this ectopic pregnancy. So if you don't see any sac in utero, or if there is a pseudo-gestational sac inside the uterus, or no double decidual sac sign, no yolk sac, no embryo, no eccentric decidual lesion within the cavity, or if there is fluid in the pouch of Douglas, or if you are seeing a mass in the adnexal area or next to the ovary, or if you see sac with the yolk sac, etc., outside the uterus, in the adnexa, in the tubal region, then you can diagnose ectopic pregnancy. But a combination of beta HCG and sonography is very, very important. Diagnosis of ectopic pregnancy is made if there is an empty uterine cavity sac with transabdominal scan, but when there is beta HCG is more than 6,000 units, or with transvaginal, the discriminatory zone is different. If you have beta HCG of 1,500 to 2,000, but if you don't see any sac inside the uterus, then you should suspect ectopic. With transabdominal, more than 6,000. So this is the transabdominal, transvaginal scan. And you see some signs also. Begel sign, that is a hyperechoic ring around the gestational sac in the adnexal region. So that then you can suspect. Or blob sign, it's seen as a small incongruous mass next to the ovary with no evidence of sac or embryo. So if you see such, then you can suspect ectopic. Or corpus luteum is useful guide when looking for ectopic, because in the ipsilateral ovary, fluid in pouch of flower and ring of fire appearance. This is a hyperechoic ring around the gestational sac, Bugle sign. And what are the differential diagnosis? Non-gynecological, as I told you, appendicitis, pancreatitis, MI, pelvic abscess, splenic rupture, perforated gas, all this, anything that causes pain abdomen. Gynecological causes are any threatened abortion, septic abortion, pelvic abscess, twisted ovarian tumor, acute PID, rupture of corpus luteum cyst, and degenerated fibroids or retrovated gravid uterus. So all these can be the differential diagnosis just as a clinical rule. Now, what is the treatment of ruptured ectopic pregnancy? If it depends on whether the patient is hemodynamically stable or unstable. If she is hemodynamically stable, evaluate the pregnancy, the patient thoroughly with all the investigation, examine her for head to toe, see a pulse, blood pressure, ultrasound, etc. Then do the counseling, take consent, arrange for blood and blood products, and shift to OT immediately, and you can do laparoscopic salpingectomy. But if the patient is hemodynamically unstable, immediately start her anti-shock treatment, start her IV line with 2 green cannulas, that big bore needles, start crystalloids, takes blood sample for hemoglobin, blood group crashing, BTCT, etc. Put a Foley's catheter, see her urine output, start colloids for volume replacement, start blood and blood products as soon as possible. You should give an emergency call to the blood bank and make an arrangement for massive transfusion, and then start blood and products as early as possible. And in older days, we didn't have transfusional sonography, and also we used to do coldocentesis to confirm. But now with the advent of very good technology, we can diagnose without all that. Then laparotomy. When the patient is unstable, we can go ahead with laparotomy. The principle in this is quick pin and quick out. Rapid exploration of the abdominal cavity is done. Salpingectomy is a definitive surgery, and you have to send it for histopathological. Blood transfusion has to be done. And when you don't have blood, if it's a rare blood group, you can do auto transfusion. So indications for laparotomy are hemodynamically unstable woman with severe intra-abdominal bleeding, corneal ectopic bleeding which is ruptured, and technical difficulties if there is a massive adhesions, dense adhesions with obesity, then this can be. Otherwise, all other cases can be managed laparoscopically. So surgical therapy for ruptured ectopic is laparoscopy bar laparotomy. Salpingostomy only in unruptured, not in ruptured, because already the tube is damaged, so you don't have much option. Here only salpingectomy. So in ruptured, unstable patient, and if the other tube is healthy, then salpingectomy is preferred because of the risk of repeat ectopic. And you should do total salpingectomy, not partial. And when you are doing salpingectomy also, and especially in laparoscopy, you should be as near to the tube as possible, and so that you don't hamper the blood supply to the ovary there, as near to the tube. And the total tube has to be taken, not partial. And in the corneal end, make it a point either to tie it or coagulate it, so that there will not be uteroperitoneal fistula later. So that is one important point. And most important point is, at the end of your surgery, look into the upper abdomen, subdiaphragmatic area or the splenic area for the blood collection. Make the head end up, and then drain all that fluid, blood, because you have to remove the blood which is collected there. If it is clot, you can do lavage with heparinized saline and remove all the clots and the blood. Otherwise, if you leave blood in this subdiaphragmatic area or splenic area, it can later get infected and form abscess. So good lavage is very, very important after this surgery. And then, and if she's stable, you can manage her in the ward. If she is still unstable, you can keep her in the ICU and manage with blood and blood products. I think if 15 minutes is over, so otherwise I won't go ahead with the other form. Or if the time is there. Hello?
Kalyan, sir?
Yeah.
Yeah, you can conclude, ma'am.
Yes, okay. Because there is so much about other sites, so I will not go in. These are just this thing: corneal, cervical pregnancy, and ovarian pregnancy and abdominal pregnancy, how we have to go ahead. Yeah, it's Z-scar. So just I had. So thank you so much, because my talk was only ruptured ectopic. I just stuck onto the tubal ectopic pregnancy. Thank you very much for this opportunity. Yes.
It was indeed a nice talk. You have covered all points about the tubal ectopic. Nowadays, there is the incidence of scar ectopic, even corneal ectopic, heterotrophic pregnancies. Because of the IVF, we need to take care of that also as soon as possible. The simple dictum is, if patient comes with a lot of pain, you don't have a sonography machine available, then you can do just POD. You can put a needle and diagnose whether there's a blood, and then you can put a laparoscope and can manage effectively if the ultrasound facilities are not available. It was an excellent talk, ma'am. Thank you so much for this talk. Dr. Kasturi, we are grateful to you. Thank you so much.
Thank you, sir. Thank you.
Over to Dr.
Thank
Monica.
you, thank you, Kalyan sir, and thank you, Kasturi ma'am, for an excellent talk. And I would request you to please answer the queries in the chat box, ma'am. I would now request Dr. Bhagyalakshmi Nayak madam to please introduce our next speaker, Dr. Suchitra Pandit madam. Bhagya
Thank
ma'am?
you so much. Yeah, can you hear me?
Yes, ma'am.
Okay. So thank you so much, Dr. Monica and the entire team of ICOG, and Dr. Parul, and Dr. Charmila, Dr. Sarita, and Dr. Everyone around. And I think it's really a pleasure to introduce icon speaker, Dr. Suchitra Pandit. I think she really doesn't need any introduction to this August gathering. But then just to be very brief about her, whatever is written is there. But I would like to say that she has been a president of the Foxy and has been really exceptional woman president. And I would tell her she has been an icon for the Gestosis Society, and she has always been on the forefront to empower the youth. So that are some of the specialties, and a very good human being in fact, and a very good orator. I think she'll speak for herself. So I don't want to waste more time on her. Let's hear to Suchitra madam. Thank you so much.
Thank you, Bhagya. First, let me just share my presentation. Is it seen?
Yeah, just opening, madam. Yeah.
Okay. Are we getting on to, is it okay?
Yes, I think a slideshow we need to do it.
Yeah. One second, hold on. I just have to do it again once more. Just a second. Now, is it okay?
Yes, madam.
Yes. Yeah. Okay. So first of all, thanks very much, Dr. Parul Kotidawala, Dr. Sarita Balerao, Dr. Charmila, and the the entire team, Parag Vinewale, and of course, Dr. Sneha Buyar, who has been consistently doing very good work. And Sneha and of course our dear Dr. Monica, they have come together with a wonderful program. And I've been listening to this program all together. And Bhagya, it's wonderful to have you chairing my session, because I always admire you as a extremely sincere worker, especially when your efforts in preventive oncology are seen. So today the topic given to me is management of hypertensive crisis or hypertensive emergency. And quickly to tell you, we all understand that HDP is the word which I'll be using for hypertensive disorders of pregnancy. It's a perplexing and a clinically challenging group of pregnancy complications and a major cause of maternal and perinatal morbidity and mortality. And it is only second to hemorrhage as a direct cause of maternal death. And preeclampsia, we understand, is a serious multi-organ complication in pregnant women with the onset of hypertension and proteinuria at a gestational week of 20 or more. And again, we understand the incidence is 13 to 37 and incidence of eclampsia is 1.8. But today we've even seen a non-proteinuric preeclampsia, wherein there is no need of proteinuria to occur, but the multi-organ complications can start off even without that. So we understand the definition, very important for you to know. It's 140 systolic or more and 90 diastolic or more, with the patient comfortably seated with an appropriate BP cuff and an appropriate methodology of taking. This is what we say is the HDP. And because HDP is a syndromic problem, there are varying clinical presentations. Therefore, there are so many screening tests, and the specificity and reliability to predict who will develop HDP or HELP is a big challenge. And just to look over, Mild to moderate is 140 to 159 systolic, and diastolic is 90 to 109. But the severe, so we say mild to moderate is the non-severe, and severe is whenever the BP is 160 or more systolic, and diastolic is 110 or more on 2 occasions. Proteinuria may be there, but the grade of proteinuria does not determine the severity. Oliguria less than 500 ml in 24 hours, cerebral visual disturbances, breathlessness, epigastric pain, right upper quadrant pain, impaired liver function, thrombocytopenia. And FGR can occur, but FGR is not important for determining severity of the preeclampsia. So any antenatal case standard for any patient for preeclampsia is screen, early prediction, aggressive treatment, use the Gist-Doses score, use the low-dose aspirin, fetal surveillance, timely delivery, and most important is prevention of eclampsia. And why do you want to do that prevention of the blood pressure? Because you want to prevent cerebrovascular accidents, the eclampsia, cardiac failure, and abruptio placentae. And remember, severe systolic hypertension is an independent risk factor for stroke. So what then constitutes a hypertensive crisis, and what would you look as a danger sign? Headache, upper quadrant pain, chest pain, visual disturbances, history of convulsions, decreased urine output, respiratory symptoms which could probably be indicating a pulmonary edema, nausea, vomiting, blindness. And though we know that hypertension affects 10% of pregnancies, many with underlying chronic hypertension, around 1 to 2% will undergo a hypertensive crisis at some point of time during their lives. Currently, we are talking about pregnancy, and therefore hypertensive crisis is probably hypertensive emergency or an urgency. And the American College defines it as a persistent acute onset severe hypertension lasting for 15 minutes or more, which is a systolic of 160 and more, or a diastolic of 110 and more in the setting of preeclampsia or eclampsia. And pregnancy can be complicated by a hypertensive crisis, sometimes even with a lower BP threshold for end organ damage than the non-pregnant patient. So we used to always think of hypertensive crisis as occurring in the antenatal period, but there is a concept of a postpartum hypertensive crisis also. In this case, there is a continuation of resolving pregnancy-associated hypertension or chronic hypertension. But there can be a situation where a de novo, completely new hypertension manifests for the first time in the postpartum period, stemming from new onset preeclampsia, and it could be a nitrogenous source, either an ergometrin, intravenous fluids, NSAIDs, or probably a neglected antenatal hypertension or a late antepartum hypertension, which is just got masked or not correctly measured, or there may be some secondary cause of hypertension. And therefore, when you're looking at postpartum eclampsia, probably preeclampsia looking at 5 to 7%, but amongst this, 24% of them can go on to a postpartum rise of blood pressure. So what is a hypertensive emergency? This always is associated with an end organ complication such as eclampsia, and therefore it is important to immediately lower the mean arterial pressure by no more than 25%, and you can get it down to at least 160 by 100. But what is a hypertensive urgency? It is not associated with any end organ complication. So you have a little more time. You can slowly lower the blood pressure with oral agents with peak effects even for 1 to 2 hours. But in an emergency, you have to be very, very prompt. So then in a hypertensive crisis, what is the management? Obviously, a high index of suspicion and prompt recognition, hospitalization, evaluation and treatment of the patient to prevent the end organ damage, immediate antihypertensive treatment for reducing the maternal blood pressure, because you want to prevent the complications. You do not want to reduce the placental perfusion and compromise the fetal growth. And at the same time, you are thinking of, now I must plan the baby's delivery as soon as possible. Magnesium sulfate to prevent convulsions, steroids for lung maturity if it is very, very preterm, but this you should do after stabilization of the blood pressure. And friends, there should be availability of an HDU or an ICU for the mother, because vigilant monitoring is very, very necessary. So the aims of this management: prompt but gradual control of blood pressure with the use of IV antihypertensives, and you want to prevent cerebral hemorrhage. So the reduction of MAP I've already mentioned before. It should be reduced by 20 to 25% within 1 to 2 hours using IV medications, with the goal systolic blood pressure to be between 140 and 150 millimeters of mercury, and diastolic to be between 90 to 100. Sudden precipitous fall can cause further complications. So friends, stabilize the blood pressure, avoid that sudden hypotension, and wherever you feel the BP is not settling down, please do call an intensivist, a cardiologist, a nephrologist, whatever that multidisciplinary team, because you need to know what is going wrong. And finally, you take a decision to terminate the pregnancy with least amount of trauma to the mother and the fetus. And there should be also availability of an NICU, because the baby may be very, very premature. So what is the type of antihypertensive agent that should be used? Obviously, the first thing is whatever is available and what the obstetrician's experience permits. Correct dosages and a rational combination of antihypertensives. And remember, a single drug is always better in small intermittent doses. Don't suddenly try to combine doses. And only if you find that you're not getting a control with one drug and you're worried about what to do with the baby, that's the time you add on the second, because you're always worried about the combination of the drugs causing side effects. And remember, because you're adding a drug into a pregnant woman's vein, she's also carrying a baby. Therefore, try to have a drug which is relatively safe with relatively less drug interactions. So what you use in a non-pregnant woman, you cannot use for a pregnant lady. And remember, it should preserve the glomerular filtration rate, the renal plasma flow. So there should be a rapid onset, but it should be sustained till you've decided what to do, and must require vigilant monitoring but minimum dose titration. So let's see what we have in our armamentarium. Labetalol. Nifedipine can be given as a first line or in combination with labetalol, but little later on. Nicardipine, hydralazine, and esmolol. Esmolol is not available in India. Hydralazine is now back to our armamentarium. And the drugs which you should avoid using is ACE inhibitors, beta blockers, atenolol, and diuretics. And friends, the last drug, sodium nitroprusside, is absolutely, you know what they say, कुछ भी नहीं हो रहा है तो sodium nitroprusside. But when you want to use that drug, you must have ECG monitoring, you must have the cardiologist, and you've already taken a decision to terminate the pregnancy because the side effects are very, very high. So this is a chart which you must put up in your labor wards. Labetalol, there are various ways of giving it, but the standard one is 20 milligrams IV bolus followed by 20 to 40 milligrams every half an hour. Max is 300, but you cannot give it in CCF asthma or in bradycardia. Use only if the pulse is more than 100. And if the pulse is bradycardic, think of nifedipine, but never sublingual. It is always orally. Give a graded dose till you start getting the BP in control, and gradually from nifedipine you can shift on to the slow release dose. Nicardipine has recently entered our armamentarium, used to be a drug of the cardiologist. Initial infusion rate is 5 milligrams per hour every 5 minutes to a maximum of 30 milligrams per hour till the desired BP is achieved. So remember, they belong, nifedipine and nicardipine, the same family of calcium channel blockers, but the advantage of nicardipine is it is 100 times more soluble than water and then nifedipine, and so it is easily titrable, and onset of action is 5 to 15 minutes. Now, hydralazine. This is a good drug and at the same time, I would say a risky drug if you don't use it correctly. So 5 milligrams IV very slowly over 1 to 2 minutes. Repeat after 20 minutes. You can give 5 to 10 milligrams IV over 2 minutes again. And if the BP is uncontrolled, you can give 5 to 10 milligrams slowly again over 2 minutes. But the maximum dose is 30 milligrams per treatment event. If you are very fast, it can cause a sudden fall, a reflex hypertension, and tachycardia. Now, labetalol different, the Cibai, Parkland, ACOG, all the regimes are correct. You have to see what you like the best. And the first one, which I told you, is the most easiest. This is a chart just to tell you that never ever give nifedipine sublingually. At the end of the day, the side effects of nausea, headache are there. Therefore, once you've stabilized your blood pressure, switch over to the sustained release dose. Now, nicardipine I've already mentioned to you, and keep it that oral tablets are also available. They produce a significant decrease in systolic and diastolic. So they can be used once your hypertensive crisis is over. And I was just talking about the hydralazine just a few minutes ago. It's the same thing which is written over here. But I'd just like to say that once the BP has settled down, you can switch over to an oral tablet like a labetalol or a nifedipine. But you should have decided by now what to do and how to terminate the pregnancy. So it's a good drug to use till you are thinking what to do, till the anesthetist come, until you've decided to terminate the pregnancy. Now, nitroglycerin, very, very short studies. It is not safe on a regular basis because there have been incidents of stillbirths in pregnant women, not big studies. So only when you have decided, abhi mujhe pregnancy nahi aage badhani hai, you have to call your cardiology friend, do an ECG, and only then you can use an NTG. So remember the PRESS syndrome, which is now becoming more and more of a common entity, where there is sudden severe hypertension with the neurological symptoms, and it manifests, it can come suddenly postpartum. For the first time, de novo hypertension, and the patient comes in a state of severe hypertension, and she sometimes is in a state of shock. So in this case, what happens is, because the BP has suddenly gone up, it can cause a forced dilatation of the vascular smooth muscle and increase blood-brain barrier permeability, and there is a cerebral edema. So in this particular case, we have to add on Maxelf, and you choose a hypertensive which is like labetalol or nicardipine rather than hydralazine or nifedipine. And magnesium sulfate is the one which must be used because it helps to dilate the cerebral vasculature and prevents convulsions if they're occurring. So Maxelf, all of us know, wonderful drug of the decade, gold standard for treatment and prevention of convulsions. For severe preeclampsia, also the Magpie trial has already shown us that it has to be used. I'm not going to go into details because we all know this drug very well, and the next speaker is going to talk in detail about Maxel. But just a word over here, in a hypertensive crisis particularly, please don't forget this wonderful drug. It very premature patients, babies 26 to 32, it also gives a neuroprotection. The doses are the same. It causes cerebral vasodilatation, reduces cerebral ischemia, and peripheral vasodilatation only. It can be given with nifedipine. And again, I'm not going to go into doses, but it's available as a 50 and 25. 50% is any time much more better. This is now an IV Max from the Bliss Pharmaceuticals, which is available. No need of calculation. It can be given straight away IV. And these are the intramuscular, the IV regimes, and both are good, but with the IV, the advantage is there is no abscess. Now, I won't go into too much detail because Dr. Girija is going to be speaking about all this, but just to tell you that the safe plasma level is 4 to 7. And important point to remember, coming to my last 3 slides, lower the BP gradually. You can use nifedipine, labetalol, you can use hydralazine, you can use nifedipine and magnesium sulfate concurrently. Maxelf is not only an hypertensive, it is principally an anticonvulsant, but whenever you are monitoring, continuous FHS monitoring is very, very necessary. And refractory hypertension, you can use sodium nitroprusside. But once the crisis is over and the patient has stabilized, Consider delivery once the patient has delivered. Please follow up for regular BP control, as these patients can have future cardiovascular problems. Postpartum BP control is very, very essential because you want to lower her future stroke risk. So counseling for lifestyle, counsel about contraception. In case they want a future pregnancy, discuss everything in detail. And observational studies have shown that breastfeeding may be associated with the lower postpartum BP. So once a condition stabilizes, do offer breastfeeding if the baby is good and with her. And in diabetic women who have hypertensive crisis, strict control of the BP reduces stroke and diabetes related mortality risks. So finally, adopt the gestosis movement. Early antenatal registration, use the gestosis score as Dr. Gorak has mentioned. It is an easy, practical tool. Women with a gestosis score of 3 or more, please start off low dose aspirin and calcium. Monitor these mothers, tag them as high risk. fetal growth को अच्छे से monitor करो. Use Maxself, be confident about using Maxself. Timely transfer of patient to a higher facility where you have the HDU and ICU, and please give Maxself to the patient before you transfer. Write on a note your beautiful transfer note, especially all the medicines you've given, and do not forget to monitor patients in the postpartum period. Enough evidence to say that these women are likely to have severe cardiovascular problems in the later period. So lifestyle changes, and advise them to come to you for a preconception counseling. Thank you very much. And once again, thank you to the brilliant ICOG team. And thanks to Bhagyalakshmi for allowing me to speak on this topic.
Thank you so much for that wonderful talk. I think a few things which I would like to reiterate for you is that I think please resist the temptation to give that sublingual nifedipine. I think we would really put it in the brains of all those who have attended this. Please don't do that. I think a gradual bringing down of the blood pressure is very important. And about the PRESS syndrome, I think everyone should keep that in mind. And please do postpartum counseling. Give a little more time to your patients. And thank you, Suchitra Madam, for that excellent talk. Thank you, Sneha, for giving me this opportunity.
Thank you. Thank you, Madam.
Thank you, Madam.
Excellent, as always. Thank you.
Thank you, Bhagyalakshmi ma'am, for sharing the session, and thank you, Suchitra ma'am, for an elaborate talk. We request you to please answer the questions in the chat box. And I would now request Dr. Anita Rajoria ma'am to please introduce our next speaker, Dr. Girija Vagnani.
Thank you, Monica. Thank you, Sneha ma'am, and thank you, team ICOG, for giving me this opportunity. Madam has already set the ball rolling. Suchitra ma'am has highlighted all the acute hypertensive crisis. Eclampsia forms the another spectrum of these complications of hypertensive disorders of pregnancy. We all know Girija ma'am so well. She is the Vice President 2024 FOXY. She's the HOD Department of OBGYN, Bharati Vidyapeeth Medical College, Pune, a very learned academician. We really feel that she is a very good academician, always so receptive to our questions and queries. She has been a real teacher, professor at International Experts General Coordinator also. She has been chair of Medical Disorder in Pregnancy Committee, FOXY. Thank you, ma'am. Thank you for accepting our invitation to talk on eclampsia. Over to you, ma'am.
Yeah, I'll just try to share my screen, and I think the bar has been set very high by already what we have listened to Suchitra madam, and the talk was absolutely excellent. I'm just trying to get my presentation on, and I hope I am able to show it in a slideshow. Is it seen?
Yes.
Yeah. So thank you, Sneha, Monica, and the entire ICOG organizing team for getting this across. And I can see that we have nearly 600 delegates who have attended, and the ICOG certificate courses are really gaining a whole lot of popularity. Thank you, Suchitra madam, for being our mentor and guide always. And thank you for setting the bar so high. And therefore, we have to see that we are able to deliver correctly for the betterment of our members and the community and the patients. So let's understand what is eclampsia. Eclampsia, as we all know, is the new onset generalized clonic seizures clonic-tonic seizures or coma in the patient with preeclampsia, and it can happen in women with HELP syndrome as well as in patients of gestational hypertension. It's not always preeclampsia, and it can also be present in patients who are normotensive. So we have to be extremely careful whenever we are dealing with any woman who is looking seemingly sick and is showing any kind of signs of hyperresponsiveness. It's very important that we be there to try to protect her from going into eclampsia. We all know that in our country, the incidence of preeclampsia has been found to be about 10.3% as per the National Eclampsia Registry. And if we look at about 26 lakh odd women delivering annually in our country, nearly 5 lakh of women would suffer from this particular condition. And therefore, it's a very, very important task. And Gorak has already said that we have to work towards zero eclampsia by 2025. And all of us therefore have to really tighten our seat belts. There is unfortunately an issue with eclampsia is the fact that despite advances in detection and management, eclampsia remains a common cause of maternal morbidity and death, especially in resource-limited regions. And therefore, we have to be extremely sensitive and there before the patient, before her seizures occur. And if they occur, we have to be very, very prompt on our treatment. Now, let's understand why seizures occur in patients of preeclampsia or hypertensive disorders of pregnancy. The popular belief is it is because of cerebral vasospasm and cerebral edema, but the current argument is it's not the only reason. The uteroplacental ischemia, which we are now understanding better, is known to cause release of certain molecules such as neurokinin B, inflammatory cytokines, endothelins, and tissue plasminogen activators. And these molecules stimulate excitatory neuronal receptors and alter the neuronal excitability, synaptic transmission, and neuronal survival independent of any vascular effects. So therefore, as a multisystemic affliction of this, what happens in the placental beds, we find that there is in eclampsia change in the neurosteroids with decreased GABA R subunits, proconvulsive effects of estradiol, imbalance of progesterone and estrogen and others. There is inflammatory and infective kind of a milieu created because of cytokine production, and there is blood-brain barrier disruption because of increased permeability factors, failure of efflux transporters, endothelial dysfunction always has been a background, we all know, autoregulatory breakthrough mechanisms are there, and there is edema formation. Now, we have always understood this basic mechanism of hypertensive disorders or preeclampsia typically, where we know that while the placenta is forming, when we should have had a wonderfully dilated perfusing vessels, very, very constricted vessels form, and this kind of multisystemic affliction occurs, which will affect the peripheral vasculature, the kidney, the liver, and the brain affliction typically is in the form of eclampsia. So this abnormal placentation gives rise to a presentation of a systemic hypertension, which usually is a late manifestation of what has happened much earlier down in the pregnancy as it started. And then there is an increase in the cerebral vasculature, vasospasm in the cerebral vasculature, cerebral edema, and then you would get seizures as the penultimate product of what has been not so good happening in the woman's body. So preeclampsia gets categorized as the CNS complications of hypertensive disorders of pregnancy. And especially when the woman has seizures, we have to be very careful to understand why they have occurred and are there any other causes as well that should come to your mind. The reason being that eclampsia is associated with a whole lot of morbidity and mortality. And as you can see, there can be short-term complications such as subarachnoid hemorrhages, intracerebral hemorrhages. There can be arterial dysfunctions and failure of autoregulation, cerebral edema, press, increased blood-brain barrier permeability, and cerebral venous sinus thrombosis. And long-term can be vascular dementia, cerebral small vessel disease, ischemic and hemorrhagic stroke, white matter hyperintensities, and increased long-term carotid intima media thicknesses. And PRES has been typically found to be associated nearly in all patients of eclampsia. And this is something which has been published from our own Pondicherry team, where they have found that there were certain kind of punctate or confluent symmetric bilateral hyperintensity in the parieto-occipital lobes of the brain on MRI. And in the CT, there were symmetric hypodensities that usually involve the occipitoparietal regions of the brain. And postulations are that it is because of vasogenic cerebral edema, ischemia of the brain tissue, and usually the posterior circulation is more susceptible, less sympathetic innervation of the vertebro-basilar vasculature to protect the parenchyma from rapid increases in the arterial blood pressure can be the possibility. And the management is discontinuing any medication if it's the cause, because it's not always that it will be associated with eclampsia, lower the blood pressure, and treat the seizures. Now let's understand the risk factors for eclampsia. Preeclampsia, gestational hypertension, of course, Black and Hispanic race, advanced maternal age, nulliparity, maternal age of 20, multifetal gestation, preterm delivery at less than 32 weeks of gestation, and lack of prenatal care. And that's somewhere where we can be aware of. In my institution, none of our antenatal registered patients suffer from eclampsia, while we have many patients being referred to us, and they are a typical mark of the fact that they must have not received a complete or coherent kind of a prenatal care. The several signs and symptoms which may precede eclampsia is something that we as clinicians have to be aware of, such as visual disturbances, blurry vision, diplopia, scotoma, photopsia, transient cortical blindness. You have to be very careful when the patient is complaining of these things. Epigastric pain and severe persistent occipital or frontal headaches. Don't always relegate it to saying that it is gastritis or something, or you're hypoglycemic or it's pregnancy related, but deep dive into finding out why she's having this problem. And the most common symptoms it's been found in presentation are headache nearly 66% of the time, visual disturbances 30% of the time, and right upper quadrant or epigastric pain nearly 25 to 30% of the times. So we have to understand that eclampsia is the most common, easily identifiable complication. Antepartum is the most common type, about 30 to 53%, but it may occur even when the woman is giving birth, between 18 to 36%, and post-birth 11 to 44%. Atypical eclampsia has been seen in less than 20 weeks, and in my tenure in my own university hospital, I have encountered about 5 to 6 atypical eclampsias, and then they did cause a lot of TZ because we had to go into differentials and to really finally say that yes, it was atypical eclampsia. There can be sometimes convulsions despite adequate magnesium sulfate dosages, and there can be convulsions even in a patient de novo 48 hours after birth, and sometimes we have had patients coming back to us in the first 6 weeks post-delivery with typical eclamptic seizures. So these seizures always, as Madam has said to us just now, have to be prevented, but if they occur, they have to be promptly treated with a bolus of intravenous magnesium followed by infusion. And intractable seizures can be in resistant eclampsia. I understand the government of India and the WHO promotes the Pritchard's regimen, which is the intramuscular regimen. But we are a tertiary care institution. We use the infusion pumps. So we can very well deliver them correctly by the infusion pump, by correcting dose and give them intravenous magnesium sulfate as well. It's very important to give them supportive care and all the rest of the things. The good news is eclampsia may be considered a preventable disease in many of the cases, and therefore that is where we have to pay attention to. Now, this confidence of it being preventable came from the very landmark publication which happened in 2002, the MACPI trial, which showed, because till that time, women with convulsions were given Lytic cocktail, and we found that it wasn't really effective, and eclampsia was very closely associated with morbidity and mortality. But then it was found that magnesium sulfate proved that it is much effective when compared to diazepam and phenytoin. And that is the time when it started getting into our practice. And I remember this was somewhere around 1992, 90 to 92 that we started using magnesium sulfate in the university hospital where I was training as a resident. In my JR-ship, we had started using it. And finally, by the time I passed out, we were well versed by using magnesium sulfate. So you can see here that this is a patient who has come at 32 years, conceived with ovulation induction, has a history of PCOS, and she has been absolutely having an uneventful course up till now.
Doctor, she's 8 months pregnant. She hasn't eaten it. I'm also feeling nauseous and also had one episode of vomiting.
Kindly mute others, please.
Headache since morning. Okay. Doctor, she's 8 months pregnant. She hasn't eaten anything since today. Okay. I'm also feeling nauseous and also had one episode of vomiting.
So you can see that she has come with these complaints and she has been advised to measure her blood pressure, and the blood pressure is now showing 170 by 100. The doctor is trying to tell her that let's check her BP, and then she immediately takes her to the bed, and there we find that she is immediately throwing a convulsion. Now you can see that there is a huge lot of struggle being done to give her an IV magnesium sulfate, and the senior consultant there is advising that you can give it intramuscularly now, and then we will take her. It's very important that once a convulsion occurs, the message here is the convulsion can occur to a patient who is sitting right in front of you in the OPD, and you have to be careful, and therefore you have to be prepared that it can happen. And this was a typical patient who had conceived with ART and PCOS. As per Gorakh's gestosis score, we can see that this turns out to be a woman who is at risk of developing HDP. It's very important to nurse the patient in the right position. The moment she has an eclampsia, turn her in a semi-recumbent and in a prone position and with a head up kind of a thing. And immediately one has to start this care algorithm for eclampsia patients. So it's 0 to 5 minutes, airway, lateral decubitus suction, oxygenation, restrain with care and protection, secure IV line, preferably 18 to 20 intracat. Deliver 4 grams of magnesium sulfate over 5 to 6 minutes. And this has to be given in a diluted form, or you can even give it in an intravenous 100 ml. I will show that as we go by. Police catheter, do her pulse oximetry for oxygen saturation, proteinuria, random blood sugar level to ensure that she is not hypoglycemic, and attach a multipara monitor. So this has to happen in the first 5 minutes of a throwing of a convulsion. Sorry for that. And at 10 to 15 minutes, your blood samples have to be taken up and sent for checking. If she is conscious, you may consider giving her a slow release nifedipine with a sip of water. Don't give it sublingually. Or labetalol 200 milligram also can be given. If the patient is unconscious, then you may consider starting her on a labetalol drip because the BP is high. And you can see in the patient 170-100 blood pressure. So you must give her antihypertensives. Magnesium sulfate infusion may be started. 24 ampules or 50% withdrawn in 50 ml syringe attached to the syringe pump, which will deliver 1 gram per hour. Or we can consider giving the Pritchard's intramuscular regimen of loading dose, 5 grams in each buttock. Assess the history, obstetric parameters, the gestational age, fetal status, Doppler or NST, and Bishop's. You can do a POCUS where you can do a bedside ultrasound to determine all this and do the Bishop score if you have an access, of course. Otherwise, you can just use a handheld Doppler and look at the fetal condition. And order for sonography with Doppler. Be wary that you should be sure that the placenta is not low-lying, and do a clinical palpation to find whether there is a concurrent abruption. At 15 to 20 minutes, you must procure the lab reports, at least the baseline ones, or on the machine or something which can give us whether her platelets are normal and what is the hemoglobin and PCV. Even that information can help you a lot by the time that your liver LFTs and RFTs come in. And magnesium sulfate delivery does not require any identification how much is the serum creatinine. You can just give her the first loading dose, which will give her an efficacy and will act on her at least for a period of 2 hours, and then we can consider giving the rest of the dosages. So don't wait for the serum creatinine level. Go ahead and give magnesium sulfate. And stabilize the patient and consider delivery, and the mode of delivery will depend on the obstetric parameters, and you may consider transferring to your HDU ICU facility, or your very, very excellent birthing centers should be good HDU kind of a setup. Now, sometimes patient may have recurrent seizures. You may consider repeating the 2-gram bolus after primary 4-gram dose. There can be refractory seizures. You may consider giving lorazepam. And if the patient continues to be unconscious, then you may have to consider maybe intubation depending on how serious she is. So this is how usually we can give. I'll just quickly run through this video.
Today I'm going to show you how to administer injection. Hi, today I'm going to show you how to administer injection MgSO4 via an infusion pump. First, I have dissolved 5 grams of injection MgSO4 in 50 ml of NS. Now I'll be installing this 50 cc syringe in the infusion pump in this manner. Now, once the syringe is installed, it will automatically show an icon where you will just have to press OK. And no drug. Again, you will have to press OK. Then you will have to adjust the dose. In this case, we'll have to administer dose as 10 ml per hour. So I'll just increase the dose as 10 ml per hour. And I'll just have to press start. And the drug is ready to be installed. Thank you.
So absolutely, you can see that it's very easy to give it with a syringe pump. But if the patients, now the reports have come and you want to consider whether I'm going to give her continued magnesium sulfate therapy or not, you remember only 3 things. Pulmonary edema, renal failure, and myasthenia gravis are the only contraindications for giving magnesium sulfate. And if you find later on, if the output is not up to the mark, we'll deal with what we are going to do. So always be ready with the magnesium sulfate box, which contains all these things. You can do your own checklisting and find out that it is well furnished and well equipped and always ready, because any woman may require this and it's not a great idea to go searching for it. Because magnesium sulfate not only prevents convulsions from recurring, but it will also abort an ongoing convulsion. So you don't have to give diazepam. And how does this do it? Blockade of glutamic N-methyl deaspartate receptors, reduce presynaptic release of neurotransmitter glutamate, potentiation of adenosine action, improved mitochondrial calcium buffering, and blockage of calcium entry via voltage-gated channels are the mechanisms in which magnesium sulfate acts. So, we are looking at various these actions of magnesium sulfate. And if you look at our partners, even Bangladesh or even in United States of America, they do not go ahead and give this Pritchard's regimens. They have the same kind of an infusion pump, and where they have a 20 ml single-use magnesium sulfate, which can be directly loaded onto an infusion pump and delivered. While in Bangladesh, I have seen that they have an actual infusion which contains magnesium sulfate, which can be delivered. And even we have one which has come up in our country. I'll be showing you at the as we go by, that we have understood that many times the problem with magnesium sulfate is that error in calculation is one of the most important things, because many centers will sometimes have to use magnesium sulfate and not always. And therefore, the strength of the delivery may of the drug may change, and therefore it's very important that we have standard dosing schedules. So this is what I was saying we have in our country currently: 4 grams of magnesium sulfate dispensed in 100 ml of infusion fluid. It's a ready-made bottle. You have to just start it and you are delivering the loading dose. And the same one later on can be considered to be given as an IV dose. So this can be given for prevention of eclampsia, as well as for abortion of a convulsion. And it can be also your loading dose in patients who have eclampsia. Now, when you're giving magnesium sulfate, it is very important that you observe both the mother and the baby. The mother, for respiratory rate, every 30 minutes, you can apply a pulse oximeter or a multipara. Blood pressure monitoring every 30 minutes, maternal pulse hourly, urine output hourly, reflexes at the completion of loading dose, and then every 2 hours. And measurement of serum magnesium sulfate levels are not necessary unless there is signs of toxicity. And if the baby is more than or equal to 26 weeks of gestation, you may consider putting a CTG, so that will give you an assurance as to how the baby is going by. You have to remember that during eclampsia, there can be a transient bradycardia or a tachycardia and some decels in the baby. That cannot be an indication for immediate termination of pregnancy. you can just stabilize the patient, keep her well oxygenated, and then deliver her once her blood pressure and all the preparation is in control and the preparation is ready. So if you look at the signs of magnesium sulfate toxicity, respiratory rate less than 10, or SpO2 less than 90, muscle paralysis, absence of reflexes are the signs of toxicity. If toxicity is suspected, cease the infusion and take blood for magnesium sulfate level. And the treatment is administering calcium gluconate 10% IV over 10 to 20 minutes. And these are the serum magnesium concentrations which we should be aware of, that 4 to 7 is the therapeutic range. If it goes for more than 7 or more than 9, then there'll be loss of patellar reflex. So your gateway and protective is the loss of patellar reflex. If the patellar reflexes are lost, monitor the patient carefully and then consider after 4-6 hours if you're giving intramuscular, whether you're going to give her the dose or not, or if you are going to continue the infusion pump, maybe you can just wait for a while and just see whether how she's going. Look at her respiration. If the respiratory rate is normal, nothing to worry. But if it is found to be less, then she's probably going into respiratory paralysis. And that would be if the level is more than 10 or 12. And if the level is more than 25 mole equivalents or more than 12.5 millimoles per liter, then she is probably going to go into a cardiac arrest. So when you're looking at the patient's response, just look at the patellar reflexes, and that can help you in identifying and respiratory rate, and that would help you guide you. And there have been large trials now coming from the WHO guideline, which have shown that magnesium sulfate is a perfectly safe medication. Now, if you have a patient of severe hypertension who is come to you, got admitted, it is absolutely prudent to give her a prophylactic magnesium sulfate when especially she is showing us any kind of symptoms, and this would help us in preventing eclampsia.
We will give her injection.
The question which is unanswered here is whether we give a loading dose or a full dose, and many a times it's always smarter to give her a full dose of magnesium sulfate because that would be definitely more therapeutic. Expectant management can be considered in such a case. You're given a prophylactic magnesium sulfate doesn't mean that you immediately deliver the patient as you would eclampsia, and don't terminate always after prophylactic magnesium sulfate. You would have a patient being brought up like this in your consultation, and she is either unconscious and she must have had a convulsion and we don't know why this happened, and there are various kinds of differentials. I know we have a wonderful talk after me which is going to speak about seizures, and there can be so many other differentials which we have to also remember. But always remember that any seizure during pregnancy should be treated, or in a patient who is unconscious should be considered to be a patient of eclampsia. So various kinds of things can also be there. There can be stroke, syncope, hypoglycemia, intracranial hemorrhage also, which is causing the mother to be unconscious. Now you can see here that this is a patient who is having seizures. And I would like to ask you a question, which you can put it in a chat box, whether which phase she is, which is the gag, what is the position, suction, anything that you want to comment. And we will look at it at the end of this disorder, at the end of this presentation. So just comment on this question, what is missing here. It's very important that you use the gag correctly and promptly, because there can be traumatic macroglossia, intubated. You can see now here the patient had such a bad macroglossia, so she had to be intubated with a lateral approach. So all these alternatives have to be kept behind. We have to remember that the hallmark feature of eclampsia is a new onset tonic-clonic type seizures. And the seizures typically last around 60 to 75 seconds, followed by a variable lasting post-ictal phase. It is a life-threatening situation, so you must call for help and activate the code blue. And since it is going to give rise to a lot of morbidity and mortality, the patient should undergo continuous intensive monitoring and not to be left alone in darkened room, and they have to be awarded respectful maternal care. So this is an ideal nursing position of a pregnant woman who is with eclampsia or severe preeclampsia. And typically there would be a well-lighted eclampsia room where you give patient any of these convulsions. And you can see that there is a first 0 to 5 minute kind of an action going on in that eclampsia room. Remember that the patient has to be restrained with care. A large bore needle has to be given. She has to be given magnesium sulfate. And she may be at risk of developing new convulsions, so she has to be protected. And you have to be very careful whenever you're trying to put in a tube or anything, because there can be a gag reflex which can occur. And it should always be wary about the fact that if there's foam or secretion coming out of her mouth, maybe she's aspirating or she has pulmonary edema. It's very important to auscultate the lungs after convulsion and then ensure that they are clear. And if not, you may consider taking an X-ray and try to find out, differentiate what it is. This is a wonderful eclampsia checklist. It looks very busy, but this is available on net. And we also have the FOXY checklists and protocols, which you can use. And this is the way in which you would take care of the patient by calling for assistance, designating a team leader, checklist reader primary, left lateral gag propped up, magnesium sulfate, ensure side rails, protect airway, continuous fetal monitoring, place IV, draw labs, administer antihypertensive therapy, develop the delivery plan, and debrief the patient, family, and the obstetric team. So these are the typical ones that you have to ensure that you are having. Now, magnesium sulfate can have minor side effects such as nausea, vomiting, muscle weakness, thirst, headache, drowsiness, and confusion, but they are just about transient and you should keep a watch for that. And we have already discussed various labs, and you must ensure that the patient's labs are seen. Her BP is monitored absolutely every 10 minutes for first hour, 15 minutes for the next hour, 30 minutes for the next hour, and every hour for 4 hours once the blood pressure is stabilized. Send the baseline labs, especially the complete blood count, platelets, liver function tests, renal function test, electrolytes, and urine protein. You can do it on dipstick immediately. And fetal monitoring surveillance as appropriate for gestational age should be considered. So these are the laboratory investigations which should be done. If you have an access to peripheral blood smear, try to find out whether she has hemolysis. And creatinine more than 0.9 milligram per deciliter is definitely assuring. More than 1.2 tells us about renal impairment, and platelets less than ₹1 lakh necessarily incite need of coagulation assessment. And any kind of HELLP can be diagnosed only by doing laboratory testing. So admit the patient and give her checklist, muse, monitoring. You can give her a gag. Once she's stabilized, she can be just put on a O2 mask and ensure that her pulse oximetry is normal. Circulation, pulse, BP, and fetal heart. D stands for drugs, magnesium sulfate, labetalol, nifedipine, and expose and explain everything to the patient and her relatives, not the patient, of course, her relatives and the team. And this is the preeclampsia early recognition tool, a little better than the Muse score, because it is taking and factoring the facts about various labs and the vitals which are essential in a woman of eclampsia. You can just write PERT on Google and get this chart. So if convulsions recur after 15 minutes, you can repeat the magnesium sulfate 2 grams, take one 10 ml syringe, draw 2 ampules of magnesium sulfate into the syringe and give IV slowly over 5 minutes. And if the patient continues to have recurrent seizures, or maybe magnesium sulfate is contraindicated, consider giving lorazepam 2 to 4 milligram IV. One may repeat after 10 to 15 minutes. Phenytoin 15 to 20 milligrams per kg IV, one dose, and may repeat 10 milligrams per kg IV after 20 minutes if no response. Avoid with hypotension and may cause cardiac arrhythmias, please remember. And Kepra is another one which is available in most of the tertiary care centers. 500 milligram IV or orally, may repeat in 12 hours. Dose adjustment needed if there is renal impairment. So respiratory depression, if you find, stop magnesium sulfate therapy, give 1 gram calcium gluconate IV, and give oxygen by mask. Maintain airway, give her recumbent position, and calcium gluconate 10%, 10 ml over 10 minutes with cardiac monitoring. If she's going into respiratory arrest, stop magnesium sulfate, calcium gluconate, intubate and ventilate immediately, and ventilation should be continued until the resumption of normal spontaneous respiration. Now, urine output, if it is less than 100 ml in 4 hours, what do we do? If there are no other signs of magnesium sulfate toxicity, the next IM dose of magnesium sulfate to be reduced to 2.5 grams, or the IV infusion to 0.5 grams per hour, and particular attention to be paid to fluid loss, balance, and blood loss. And then you have to do risk stratification and complication management in our patient. If she has pulmonary edema or cyanosis, epigastric and pain, impaired liver function, thrombocytopenia, hemolysis, or HLLP, coagulopathy, oliguria less than 30 ml per hour for 2 consecutive hours, prompt evaluation and communication, and may be considered delivery ho. And fetal indications would be an abnormal fetal tracing FGR. But remember that while the patient is on antihypertensives and on magnesium sulfate and convulsing, there can be a little jeopardy, which can be transient. Now, many times, the time and route of delivery is a big question, and eclampsia has to be delivered after stabilization. Route of delivery will be determined by the obstetric indication, and continue control with oral agents, and the target range of blood pressure has to be between 140 to 150 systolic and 90 to 100 diastolic. And you may consider delivery once your patient is stabilized, but not postponed it for more than 48 hours. Special delivery decisions: if preterm less than 34, antenatal corticosteroids, subsequent pharmacotherapy. Look for HELLP, delay delivery for 24 to 48 hours if maternal fetal condition remains stable only. Contraindications for delaying delivery for fetal benefit of corticosteroids is uncontrolled hypertension, eclampsia, pulmonary edema, suspected abruption, DIC, non-reassuring fetal status, and intrauterine fetal demise. Be very careful about fluid management. It's very important to prevent overload, because there should be unnecessarily too much of fluid can give rise to problems. So restrict fluids to 80 ml per hour or 1 ml per kg per hour is beneficial. Preload with a fixed volume, especially like a normal C-section, would be hazardous, so be careful. Higher, so you can consider giving a co-load. Hypotension to be treated with vasopressors as an infusion or slow boluses. And oliguria is quite common and obligatory, and less than 15 ml per hour does not need aggressive hydration, so be careful. We have to remember that these women, and this is coming from the maternal death analysis in the confidential inquiry, and it was found that edema kills the patient. And therefore, we have to be very careful because of excessive capillary fragility. There can be reduced cardiac output, a leaky vessel syndrome kind of a thing. And this would be a terrible picture that a woman would have, and it would be very difficult to salvage her. It's very careful to be postpartum. Look at the patient, you can see.
Find the baby, it is fine. And since you had high BP before delivery, so if you have blurring of vision, headache, nausea or vomiting anytime, then report to the hospital urgently. Yes, doctor, I'm having headache. Get the BP app.
And you can see that the patient is all ready to go home, and she has been stabilized, but still she's thrown a convulsion. So your postpartum surveillance is very, very important. It's necessary to prevent additional morbidity, as preeclampsia, eclampsia can develop postpartum. Inpatient measure blood pressure every 4 hours after delivery until stable. Do not use NSAIDs for women with elevated blood pressure. Do not discharge patients until BP is well controlled for at least 24 hours. In an outpatient care for patients with preeclampsia or eclampsia, visiting nurse evaluation is recommended within 3 to 5 days, and again in 7 to 10 days after delivery, earlier in persistent symptoms. And we have a good network of Asha Bai, or we can ask the relatives to bring her, or maybe communicate on phone or on video consultation. Antihypertensive therapy is recommended for persistent postpartum hypertension of 150 systolic blood pressure and 100 diastolic, at least 2 occasions or at least 4 hours apart. And persistent systolic blood pressure of 160 or DBP of 110 should be treated within 1 hour. And this is something that should be a part of a patient's early warning sign counseling when she is discharged. Always be well equipped in your facility with the eclampsia room checklist, oxygen, maternal and neonatal resuscitation facilities, kit of eclampsia, protocols, and documentation. And this is something that you have to keep on refurbishing and ensuring that it is in place, because any duty, any time, 24/7, these women can walk into your clinic. So a lot has been understood now, and therefore we wouldn't be able to excuse ourselves where we are not able to deliver what is supposed to be. But there are certain questions which we require to still answer, and these are the thoughts for the future. Determine the optimal duration for magnesium sulfate prophylaxis after delivery for women with preeclampsia with severe features, and assess whether women presenting with late postpartum preeclampsia with severe features more than 48 hours after delivery will benefit from magnesium sulfate prophylaxis. At the current time, we are using whatever wisdom and research that is, and we are offering it. but these are the questions which have to be answered. Thank you so much for giving me this opportunity. I hope I have been able to deliver what was expected of me of this certificate course. Thank you so much.
Thank you, Girija ma'am. You have highlighted all the important points in great details. It is very, very important that we do not lose monitoring patient in postpartum phase. It is very, very important. You have reiterated it time and again that even if your patient had normal blood pressure in antepartum and intrapartum course, be very, very vigilant in postpartum phase. We have encountered so many postpartum eclampsia because the BP was not recorded properly for early. We must remember that around 10 to 40% they say can be postpartum eclampsia. And thank you for highlighting that the whole, magnesium sulfate initial loading dose, everything should be displayed in the labor room with ready eclampsia kits there. Then in there, everything should be together so that we do not create panic at the last moment when our patient is throwing convulsion. And ultimate, the treatment is the termination after stabilization of the patient. Thank you, ma'am, for highlighting that. And one more important thing is close monitoring, because it is a cause of very high maternal and perinatal morbidity and mortality. Thank you so much, ma'am. Thank you for giving a detailed account. And another thing is, you showed those beautiful drills. We must conduct these drills with our residents. Because actually at that last moment when they have to do everything together, they must have these regular drills so that they are acclimatized and accustomed, so that one person assumes the team leader role and other follow instruction. Thank you, ma'am. Thank you for showing those nice videos. Over to organizers.
Thank you, Anita ma'am, and thank you, Suchitra ma'am. Yes, ma'am. Suchitra ma'am.
Girija, excellent talk. Very nice. Very nicely. The practical tips and the drills were very, very good.
Thank you so much. Thanks to my team here. They did it on their own. I just gave them a scenario and they do it. Thank you.
Thank you, ma'am.
Excellent, Girija. Thank you so much.
Can I now request Dr. Mumtaz madam to please introduce Muralidhar sir?
Thank you, Monica. Thank you, Sneha ma'am, for this wonderful opportunity. And I also congratulate you for organizing all this. I've been always working in all fronts, whether it is academics or health education, you're always there. So big congratulations and thanks to the whole team behind this. Now it's a pleasure and privilege to introduce my own teacher, Professor Dr. Muralidhar Pai. Sir is a teacher par excellence. Everyone who has been his student or everyone who has listened to him once will definitely agree with me. He has a different way of approaching things and a very, very different and way of presenting things which will remain in our minds for a very long time. So here we have Professor Dr. Muralidhar Pai, who is a Dean at Sikkim Manipal Institute of Medical Sciences currently. Sir has more than 35 years of academics, more than 20 awards and many fellowships, international fellowships. So it's a pleasure to introduce you, Dr. Muralidhar Pai. And now we are going to listen to seizures in pregnancy. Till now we are listening to hypertensive disorders and eclampsia. So over to you, Murali sir. We are all ears.
Thank you.
Sir, just 1 minute before you start, sir. Sir, we have been receiving calls from the ICOG office that we will be required to finish in time. So I request all the faculties to please stick to the time limits.
Yeah, sure. Mine is very short. Don't worry. Yeah.
And thank you, please.
Yeah. So thank you very much, Mumtaz, for the nice introduction, and thank the ICOG for inviting me for this talk. And I must appreciate, I was listening to both Dr. Suchitra and Dr. Girija. They were excellent talks. So we have to just come out of preeclampsia and eclampsia. These are neurological seizure disorders. They are not connected to actually preeclampsia. They are independent of preeclampsia and they can occur anytime. Usually the teaching is that whenever a pregnant lady throws fits, unless proved otherwise, it is due to eclampsia. But here is a problem which can occur even in early pregnancy. and any time of pregnancy without the patient having hypertension or any other problems of preeclampsia. So that's what I'm going to talk about. What is seizure? Seizure is a paroxysmal disorder of the central nervous system. So it just happens. Paroxysmal means it can happen anytime. Suddenly it comes like a bolt from the blue. It is characterized by an abnormal neuronal discharge. Dr. Girija was telling that the seizure need not always be due to hypertension. It is due to chemicals that will excite the neurological system. Here, that is the case. And with or without loss of consciousness. Whenever a person has seizure, not always she has to lose the conscious. What is epilepsy? Now, epilepsy encompasses different syndromes whose cardinal feature is a predisposition to recurrent. I have made this word recurrent very big and bold because that is the typical feature of epilepsy. It has to recur and it is unprovoked. Whereas in eclampsia, you could have so many provocative factors, but here this is unprovoked. There is no provocation for this particular seizure. The incidence is thankfully very less. It is 0.15% of all pregnancies. And in India, 40% of epileptics are women of childbearing age. That's how, even though the incidence is less, most of the women are in this age group. Epileptic women are in this age group. Nearly 2 to 3 million potential mothers suffer from seizure disorders. Let's now look at the classification. It is divided into focal, where they have origin in one area in the brain and affect a corresponding area of the neurological function. So it is focal, focused to one particular area only. They can result from trauma, abscess, tumor, or perinatal factors, although a specific lesion is rarely demonstrated. So you cannot pinpoint a particular lesion in the brain, but there could be sometimes trauma, concussion, other things. They can also throw a fit. This is focal. Whereas generalized, they involve both brain hemispheres and are usually preceded by an aura before an abrupt loss of consciousness. That is very important here. Abrupt loss of consciousness is very, very important. And they usually have a aura. That is very pertinent to note. It is hereditary. That is the issue. The generalized seizure is a hereditary problem. Now, in generalized tonic-clonic seizures, the loss of consciousness occurs, which is followed by tonic contractions of the muscles and rigid posturing. So this all of us are well aware of. And then by clonic contractions, patient gradually returns to consciousness. So patient may or may not remember what happened after losing the consciousness. Patient will remain confused and disoriented for several hours. Though she regains the consciousness, she remains confused and disoriented for several hours. Absence seizure is also called petit mal seizures. Here, it's a form of generalized epilepsy that involves a brief loss of consciousness without muscle activity and are characterized by immediate recovery of consciousness and orientation. So you won't see those clonic contractions and shaking of the body, but there is a brief loss of consciousness, but immediately she recovers. Patient won't even realize that she went into a seizure. Even others also may not realize this. This is absence seizures. As the name suggests, there is no seizure attack as such, but there is brief loss of consciousness. What are the causes? Now, as we mentioned earlier, as in case of a focal seizure, most of the seizures may have a trauma history, or it could be because of alcohol and other drug-induced withdrawals. We have seen that. And cerebral infections. Post-infection, there can be seizures. Brain tumors. If not trauma, it can be because of the tumors. Or it could be simply biochemical abnormalities, as the neurotransmitters are abnormal. It could also be due to arteriovenous malformations in the brain. And finally, we land up with idiopathic, which is typically epilepsy, usually diagnosed by exclusion of the above. That means there is no history of trauma, no history of alcohol or drug intake, no infections, no tumors, no biochemical abnormalities or arteriovenous malformations. Then you brand her as a case of simple or pure epilepsy. So what is the preconceptional counseling to be done? Because this is a problem of preconception, unlike preeclampsia and eclampsia, which occurs only after she becomes pregnant. So preconceptional counseling is extremely important here. Women with epilepsy have 2 to 3-fold risk of having infants with seizure structural anomalies compared with unaffected women. So this has to be kept in mind. This structural anomaly could either be due to the disease itself or because of the drugs that she takes for the disease. Seizure should be controlled preconceptionally, preferably by monotherapy. Again, as you can see, I have made biggest font possible and bold possible. That is monotherapy. Usually patients are on multiple anti-seizure drugs. It has to be converted to monotherapy if she is planning conception. Valproic acid should be avoided as it has got increased teratogenic effect. As I told you, the seizure disorder itself and the drugs used for seizure disorders, in that valproic acid can cause teratogenic effect. So it should be avoided. Supplemental folic acid 0.4 milligrams at least once 1 month before the conception, and once she conceives, it has to be increased to 4 milligrams. Now let us look at what is the effect of pregnancy on epilepsy. Does pregnancy increase the seizure risk? Research does not indicate any increase in the frequency of seizures purely due to pregnancy. Now, having said that, we see sometimes there is an increase in the seizures. The incidence of seizures have been further controlled with newer refined techniques of prescribing optimum dosage of anti-epileptics. But as I said, in some patients, if at all you see there is an increased seizure frequency, it is associated with subtherapeutic anticonvulsant serum levels. Now, why does that happen? As you all know, there's a whole lot of physiological changes that is happening during pregnancy. So there may be actually decreased absorption or increased elimination of the drugs from the body. And it could be lower seizure threshold during pregnancy or both. Now, what is this subtherapeutic level? It may result from pregnancy-induced nausea, vomiting, as I said, decreased absorption, generally due to decreased GI motility that diminish the drug absorption or hypervolemia. Or it could be hepatic and placental enzymes that metabolize the drug. So that's why there is decreased or subtherapeutic levels. Finally, as I said, secretion also is more. We all know the GFR is increased during pregnancy. So as a result, it hastens the drug clearance. So first of all, absorption is reduced, metabolization is increased, clearance is also increased. So whatever dosage that you were giving before pregnancy now looks less. And that's why apparently it seems there is an increase in seizure. But pregnancy per se does not increase the seizures. That's what I want to clarify. Now further, let us see what is the effect of epilepsy on pregnancy. We saw the effect of pregnancy on epilepsy, but now let us look at effect of epilepsy on pregnancy. This following increase are seen due to epilepsy per se, 2-fold increase in cesarean delivery, as usual, maybe because of fetal distress and other things. 1.5-fold increase in preeclampsia and PPH. Now, preeclampsia is one thing. Epilepsy predisposing preeclampsia is another thing. So there is a 1.5-fold increase in preeclampsia and PPH. So the incidence of non-proteinuric hypertension, labor induction, and postpartum depression all are increased during and after pregnancy because of epilepsy. Further, let us see, there is a hereditary effect. An epileptic mother has 1:30 chances of producing an offspring with a seizure disorder, although the exact mode of inheritance is not known. Right in the beginning, I told seizure disorder is hereditary. So that effect will be there on the pregnancy in terms of offspring getting 1:30 chance. And then, as I said, apart from the drugs that has teratogenic effect, epilepsy itself can cause malformations. Currently, this is the major hazard that a pregnant epileptic mother faces. And all of us are aware the drug that can cause teratogenicity, fetal hydantoin syndrome. Hydantoin is one of the drugs used for epilepsies. In 1976 itself, Hansen described this, and it comprises of microcephaly, mild to moderate mental retardation, developmental delays, prenatal and postnatal growth retardation, facial clefts and dysmorphisms, finger-like thumbs, and distal phalangeal and nail hyperplasia. So what are the other effects of phenytoin? There's an increased incidence of congenital heart defects other than what is mentioned in the previous slide. Wilms tumor, vitamin deficiency, T deficiency, hypocalcemia and tetany, neonatal coagulopathy due to vitamin K deficiency, and the incidence of such anomalies is as high as 7 to 11%, which is alarming. So further, it is believed that many anomalies are related to the more existence of epilepsy itself. Now, it is not the disease or the drug. It is because of the epilepsy, that is the seizure part of it. This is because these women have a high risk of seizures, which may cause injuries, abruption, periods of fetal hypoxia, FGR, and IUFT. So this is due to the epilepsy process, not the disease or not the drug. I hope it is clear. Infants exposed to barbiturates are often drowsy and may suffer barbiturate withdrawal in the first week. It's like drug withdrawal. Now, what is the treatment of epilepsy? Of course, whenever there is epilepsy, we have to give anticonvulsives. But here, we do not use magnesium sulfate because the reason for using magnesium sulfate is different in preeclampsia and eclampsia. Here in pregnancy, the physiological increase in the blood volume, nausea, vomiting, decreased gastric motility, and non-compliance are important causes of decline in circulating drug levels. So we have to make good of them. This could aggravate the frequency of seizures. So careful drug level monitoring. You don't have to start a new drug, but the same drug which she has been getting, the monotherapy under which there was a control, we have to consider the increase in the dosage for the reasons which mentioned above. Further, phenytoin and barbiturates are known to accelerate hydroxylation reactions in the liver by inducing microsomal enzymes. That is the reason there is a rapid turnover of folic acids. That's why folic acid from 0.4 before pregnancy goes up to 4 milligrams after pregnancy. This is the wonder drug that is now being even used for after the control of eclampsia with magnesium sulfate. When you give neurologic consultation, they start this drug, levetiracetam. This is straightaway used in epilepsies. It's a newer anticonvulsant. Exact mechanism is not known. However, it works by slowing abnormal nerve impulses in the brain. It does not pose a major risk to the neurological development of the fetus. That's why it is preferred in pregnancy. It is given in 500 milligrams twice a day orally. Additional dosaging increments may be given up to 1,000 milligrams per day, additional every 2 weeks, to a maximum of recommended 3,000. I have never seen anybody receiving 3,000 milligrams. Maybe 500 milligrams twice a day I have seen. So there should be a pre-conceptual counseling, prolonged seizure-free rapid taper off and discontinue antiepileptics prior pregnancy. If at all there has been a long gap of seizures, grand mal epilepsy should be treated with first with phenobarbital. If patients have complex partial seizures, primidone and carbamazepine is worth a first try. During pregnancy, seizures are controlled and she is pregnant. No attempt is made to change the medication or dosage just because you want to change the dosage. Okay, I'm completing in 1 minute. If possible, monodrug therapy is preferred and trimethadone and valproate should not be given. Folate supplementation should be increased, as I said, and encouraged to take medication regularly, not to deprive herself of sleep. Should she experience excessive vomiting, she is advised antiemetics. Anticonvulsant drugs should be frequently monitored and dosages should be adjusted. Ultrasound fetal echo should be done because we know that there is a chance of baby having problems. And vitamin K from 34 weeks should be given because it is reduced due to phenytoin drugs. Cesarean is only for obstetric indication. Just because she's a patient of epilepsy, you don't have to do cesarean section. A neonatologist should always attend the delivery because there's a small chance of the baby also can having the problem. All babies must be administered 1 milligram of vitamin K. So in conclusion, epilepsy is not a contraindication to pregnancy, and cooperation between the doctors and patients often ensures a favorable outcome in most cases. All that you need to do is adjust the dosage of the drug which she's been taking before pregnancy, and of course it better be monotherapy, and keep monitoring her very closely. There is no need to unnecessarily get into obstetric complications of cesarean section unless she develops other complications or obstetric indications are there. Thank you so much for your patient listening. I hope I was in time.
Thank you, sir, for a crisp presentation, but it has covered almost all the points. There are some queries in the chat box, sir. You can answer to them at your leisure. Can we have the slides for the next session, Nilima ma'am? Thank you so much, sir. And
thank you so much, respected sir, for accepting our invitation, and thank you, sir, for that excellent talk. Thank you. Thank you.
Thank you, Mumtaz ma'am, for sharing the session also. I would now like to introduce our chairpersons for the next session, Dr. Subhash Malia. He is the chairperson of the Foxy Endoscopy Committee for the year 21 to 24. And he is a part of the member specialist board of the NBE for the minimal invasive gynecology. He is also the chairperson of the medical legal committee of the KFOG. We welcome you, sir. Our next chairperson. Can we have the next slide, please? Dr. Sampat Kumari, madam. She is the president board of studies of the Tamil Nadu MGR Medical University. She is also the deputy director and professor of the Institute of OBGY MMC Chennai and vice president of Foxy. We welcome you, ma'am. Our next chairperson for today's session is Dr. Bhayapati Maheshwari, madam. She has been the past chairperson of the Foxy MGP committee. She has held various posts, and she is part of the professor and head of the department of the Muzaffarnagar Medical College at Muzaffarnagar. We welcome you, ma'am. Dr. Mumtaz has been introduced in the previous session, so I will just skip this slide. Our next chairperson is Dr. Brijbala Tiwari, ma'am. She is the president of the Indore OBGY Society and the vice president of the Indian Medical Association of Indore, branch and Indore Menopause chapters. She is the NICEBOB chapter secretary too. We welcome you, ma'am. I now would like Dr. Subhash Malia, sir, to please introduce our first speaker for today, Dr. Manjupuri, madam. Over to you, Subhash, sir.
I don't
Sir,
think
please unmute yourself. Ma'am, he is there. I can see him.
Yeah, I was not able to unmute, Monica. Thank you. Right.
Yes. Welcome, Subhash. Welcome.
Yeah. Hi, ma'am. Hi, ma'am. Right. I would like to welcome the first speaker for the evening, ma'am, for adolescent pregnancy, Dr. Manjupuri, ma'am, Professor Manjupuri, madam. She's a direct professor of Lady Harding, Delhi, and she's also been the past national advisor to the Practical Obstetric Committee of Foxy. Also, she's also been an active member of AOG and also been the past president of. She's also had quite a few textbooks, to her as an editor. Madam has also been an editor for the neonatology book also. And more importantly, madam is a wonderful human being. And madam has actually given me a lot of good advices previously when we met in Ambala also. Thank you very much, ma'am. And looking forward to your talk, ma'am. Welcome you, ma'am.
Thank you, Dr. Subhash. And thank you, ICOG, for having me here. And it is indeed always a pleasure to be, participating in these richly academic events. So I'll share my screen and hello, am I audible?
Yes, ma'am.
Madam, you're audible, but your screen is still showing screen
Not
sharing.
yet visible, ma'am.
So I think
Yeah, just a second. I'll just do it once again. Give me a moment. Yeah.
And thank you so much, madam, for accepting my invitation. And thank you so much for being here. Thank you.
Okay, so is the screen visible now?
Yes, ma'am.
Yes, madam.
All right. So sorry for this glitch. So I'll just start. My talk is on acute breathlessness in pregnancy. Now, we all know that shortness of breath or breathless is medically known as dyspnea. And if the onset of dyspnea is gradual and without any other symptoms, it is probably physiological and occurs in about 60 to 70% of healthy pregnant women. But dyspnea of sudden onset, accompanied with features like cough, symptoms like cough, chest pain, or wheezing, is more likely to be pathological and requires a detailed evaluation. So, the sudden onset dyspnea can be due to an underlying or a coincidental cardiac or pulmonary condition. So whenever we are dealing with our pregnant, mothers, tachycardia and, raised respiratory rate are two things which should really make you uncomfortable. So the outline of my talk would be to, touch upon the physiological changes in respiratory and cardiovascular systems and their clinical implications, list the causes of dyspnea in pregnancy, discuss the importance of history and examination in differentiating between the dyspnea of cardiac and pulmonary origin, discuss the investigations and their interpretation, and discuss the role of POCUS, that is point of care ultrasound for rapid diagnosis, which is fast emerging. Now, looking at the normal cardiovascular adaptations of pregnancy, we all know that pregnancy is a hyperdynamic state wherein the cardiac output increases. You can see this blue line going up, and this cardiac output increases because the plasma volume increases. And, consequent to that, there is increase in cardiac output or increase in stroke volume. Also, you can see that the heart rate, that increases. This red line is the heart rate. So that increases. And then if you look at, these are the things which are increasing. But if we look at the vascular resistance, the progesterone, which is the muscle relaxant, it reduces the systemic vascular resistance. And once the systemic vascular resistance, this is the blue line here, is the systemic vascular resistance, it starts decreasing right from 6 weeks onwards, once the progesterone is there in the circulation. And this also leads on to a fall in the blood pressure of the patient. If you can see the diastolic blood pressure, the systolic blood pressure also falls in the mid-trimester and then picks up. So these are the basic changes which happen. And because of the increase in stroke volume and increase in cardiac output, the left ventricular diastolic dimensions are more, and even the left atrial size is more during pregnancy. Now, looking at the physiological changes in the respiratory and the circulatory system of pregnancy, we know that in pregnancy, the diaphragm gets elevated. There's widening of the AP and the transverse diameter of the chest. The chest compliance decreases, but the lung compliance is normal. And there is an increase in respiratory drive because of the progesterone, effect of progesterone on the respiratory center. The woman breathes more deeply, and there is carbon dioxide washout. And at the same time, we know that, the oxygen consumption increases both by the fetus and also by the mother herself. And we want a higher gradient between the oxygen and the carbon dioxide so that the fetus can transfer these, oxygen can get transferred from the mother to the fetus and carbon dioxide from the fetus to the mother. So what happens in the respiratory, changes, functions is that the total lung capacity, residual volume, the functional residual capacity, all this decreases because the patient is breathing deeply. The tidal volume increases, the minute ventilation increases, and, the oxygen consumption also increases. And at the same time, there is decrease in pulmonary vascular resistance, again, because of the effect of the progesterones. Additionally, there are some changes in the circulatory system, which are also important when we talk about acute breathlessness in pregnancy. We know that the colloid osmotic pressure decreases, so the patient is more predisposed to pulmonary edema. And the coagulation increases, the coagulation factors increase, the patient is, the pregnancy is a hypercoagulable state, and the blood circulation, especially in the lower limbs, decreases. Okay, and also because of the, decreased resistance, the blood circulation slows down, so the patient is predisposed, the mother is predisposed to embolism. So that is a very important factor. Now, applying the respiratory changes onto the interpretation of arterial blood gas analysis in pregnancy, which is a very important investigation when we have a patient who comes with breathlessness. We should know that pregnancy is a state of chronic, compensated chronic respiratory alkalosis, because there is washout of carbon dioxide. So if you look at this, the pH normally in non-pregnant is 7.35 to 7.45. Here it is higher. So it is 7.40 to 7.46. So if you have a pH less than 7.4 in pregnancy, then we have to be concerned. And if you look at the oxygen, the PaO2, in non-pregnant it is 80 to 100, but in pregnancy it is 95 to 105. So that is why it is important to interpret it. So PaO2 of 80 may not be okay in pregnancy. Likewise, if we look at PaCO2, it decreases because there's a washout. So 35 to 45 is in non-pregnant, and 27 to 34. So if it is 34, 35, then that means it is not normal. So we should know that the carbon dioxide in a pregnant woman is lower. Likewise, bicarbonate, because there is a metabolic compensation. So the normal bicarbonate in non-pregnant is 22 to 26 milliequivalents per liter, but in a pregnant woman, it would be 18 to 21. And likewise, the oxygen saturation, which you measure with the help of a normally which we would measure in our clinics, it can be 93 to 100% in non-pregnant, but in pregnancy it has to be 95%, the lowermost limit. So this is important, because when we look at the ABG, we must know that this is what the normal pregnant values are like. Now, what are the causes of dyspnea in pregnancy? The most common is physiological. We must remember it starts early in pregnancy, in the first and second trimester. It improves as the pregnancy reaches term, whereas pathological dyspneas would worsen as the pregnancy advances. It is, the patient is more comfortable at, lying down, and it is more, severe when the patient is sitting. Contrary to in cardiac problems, if the patient lies down, there is more, she's more uncomfortable, vis-a-vis if she's sitting down. So these are the kind of differences between the two. And the ABG and the chest, everything would be normal in physiological dyspnea. Now, there are certain causes which are related to pregnancy. They are pregnancy-specific conditions. The most common is pulmonary edema. Pulmonary edema due to preeclampsia. We've already had a nice discussion by Dr. Girija, who's highlighted this, that in preeclampsia, whenever the blood pressure is, with this uncontrolled hypertension, the patient tends to go into pulmonary edema. Likewise, because there is hemoconcentration and the compartment, there is, the blood vessels are contracted. Even smaller amount of fluid, if you give IV fluid, the patient can go into pulmonary edema, and especially in the setting of low oncotic pressure, which we've already said. Tocolysis is another, especially, we are not giving beta-2 mimetics now, but beta-2 mimetics do lead to tachycardia and sodium and water retention. And tocolysis combined with corticosteroids can definitely precipitate pulmonary edema. Likewise, induction of labor with oxytocin can also precipitate. This is especially true when we are doing it for the second trimester abortions and all, because there we tend to give it for longer period and in higher doses. The second important pregnancy-specific condition is amniotic fluid embolism, which is more like an anaphylaxis to the amniotic fluid. So we all know that it is a very serious complication. Peripartum cardiomyopathy also comes towards the later half of pregnancy, and this is another very common cause which we do find out can contribute to acute breathlessness. Gestational trophoblastic disease, we know that can contribute to, respiratory distress through embolism, and also through, sometimes, they have thyrotoxicosis. So all that can precipitate dyspnea. Hydroamnios, by exerting pressure, it can cause respiratory distress. Then there are pathological conditions which are coincidental to pregnancy. So not specific to pregnancy, but they can be there with the pregnancy. So here we have pneumonia. We all have gone through that COVID, times. So it can be bacterial, it can be viral. For, We know that we have lots of atypical viral pneumonias these days. Pulmonary embolism, I've already told you, pregnancy is a hypercoagulable state and the circulation is slower, so more chances of embolism. Then ARDS, it could be because of sepsis, could be because of aspiration pneumonitis or massive blood transfusion. So all this can give rise to adult respiratory distress syndrome. And then asthma, we know that it is pretty common given the pollution which we have these days. Then upper airway obstruction can also happen in anaphylaxis. Any drug reaction, can give rise to spasm and then can give rise to, respiratory distress. Spontaneous pneumothorax can be there. And also pleuritis, due to tuberculosis, that is also quite a common thing. All these can give rise to dyspnea. Now, looking at the cause of acute dyspnea, so we need to differentiate between the respiratory and the cardiac problem. So in respiratory, we have obstructive airway disease, parenchymal and interstitial lung disease, we have vascular disease and pleural disease. And this side, we have cardiomyopathies, we have, ischemic heart disease, we can have, the valvular diseases or pulmonary arterial hypertension. So in history, we need to look at the time in relation to gestational age. I said that cardiomyopathies would come later, amniotic fluid embolism would be related to delivery and things like that. Then we look at associated symptoms like cough, wheeze, chest pain, orthopnea, fever, swelling of lower limbs, palpitation and syncopal attacks. All these would mean that it is more of pathological in origin. We also find out whether there's history of hypertension in pregnancy, any history of drugs like oxytocin, tocolytics, even NFT can give rise to respiratory distress. Any past history of COVID, all those who've had, the bad COVID can have pulmonary arterial hypertension and can decompensate suddenly without any reason. Then history of heart diseases, asthma, deep vein thrombosis or pyelonephritis or any blood transfusion, any recurrent chest infection in the past, all these histories have to be elicited. Looking at the examination, we take a note of the pulse, the blood pressure, the respiratory rate. Sometimes the respiratory rate may be fast, but the accessory muscles may not be working. So that is important. If they are working, that means, it is, it is abnormal. Then we also look at the, oxygen saturation, look at take the temperature, pallor, cyanosis, clubbing, JVP, any thyroid enlargement, pedal edema, any scars suggestive of tuberculosis on the neck or any lymphadenopathy. We auscultate the chest and we look at the auscultate the CVS. So in CVS, there are certain findings which are in pregnancy which are actually not abnormal. The JVP may be slightly raised, the systolic murmurs of grade 2 or less than grade 2. And then pedal edema may be there in normal women pregnancy, and also occasional ectopic beats. And the saturation is always more than 95%. Now, in what is abnormal? So all these are normal. So if a patient has cyanosis, she has clubbing of nails, she has distended neck veins, she has thrill, which is palpable, or she has diastolic murmurs or systolic murmurs, which are more than grade 2, and or she has persistent arrhythmias. All this is abnormal. What investigation should we order for? So CBC with peripheral smear, this will give you a clue whether there's any infection or is the patient anemic. A coagulation profile for ruling out amniotic fluid embolism, or sometimes in sepsis also this gets affected. Then D-dimer. D-dimer normally also is raised in pregnancy, but anything more than, different people give different values. More than 1,000 is definitely abnormal. More than 800 also is abnormal. But some people might consider more than 500 also as abnormal. So X-ray chest with abdominal shielding, ABG analysis, urine examination for ruling out, urinary tract infection. Then we have these biomarkers, pro-BNP, ECG, echocardiography, then sputum for AFB and culture sensitivity, thyroid function test. Then we have Doppler of the veins, leg veins, in case we are suspecting, pulmonary embolism. And then, of course, computed tomography, pulmonary angiography, again to rule out pulmonary embolism. The last is POCUS, that is point of care, called point of care ultrasonography. So this is a small algorithm which I would take you through. So we take a detailed history and examination, rule out asthma. Then we order for chest X-ray, ABG and ECG. So this is the basic workup. Of course, we do a CBC with peripheral smear. And if the X-ray, chest, ABG and ECG all are normal, then we just look at the hematocrit to rule out anemia. If the patient is got a hematocrit which is low, it is anemia. In case it is more, then we think it is psychogenic hyperventilation state or physiological dyspnea of pregnancy. Now, if the X-ray chest is normal, but ABG is abnormal, and the ECG may be normal or abnormal, so it is basically with the X-ray chest. If the X-ray chest is normal, then we think either in terms of embolism, okay, and okay, just 2 minutes. And if the X-ray chest is abnormal, then we think more in terms of, we want to find out whether the primary cause is either cardiac disease or is it primary pathology, which is lung. So this is what it is. So basically, if your ABG is abnormal and X-ray chest is normal, then we would go more in terms of pulmonary embolism. So that means we can take the patient for either a CT, pulmonary angiography, or even a VQ scan, that is ventilation perfusion scan. So we would decide it accordingly. So now, looking at the cardiac biomarkers which are new. So BNP and pro-BNP are two markers which are very important, which if positive, will favor a cardiac origin. So we must remember that we have these markers handy now, and they have a very high negative predictive value. So BNP is less than 100 or a pro-BNP less than 128. It has a very high negative value. So that means we are by and large ruling out the cardiac part. Then a word about the safety of diagnostic procedures. We should not hesitate in doing X-ray with abdominal shielding. We also should not hesitate in doing CT pulmonary angiography. The exposure which goes to the fetus is much lower than what can have a detrimental effect. A word about point of care ultrasound. This is coming in a big way. And they say that by the time you wait for echocardiography or you wait for ECG and X-ray chest, if you know the ultrasound, you can just do a point of care ultrasound, and which has got a very good accuracy. So this is what is a blue protocol. This is bedside lung ultrasonography, which can be done by emergency. We all know ultrasound, so I think we all can do it. So you just have to do a few sweeps, and you can know whether there is pulmonary edema or not. So you get these, lines, B lines running from top to bottom, and this is what identifies pulmonary edema. You can also do a cardiac evaluation by just 3 views. You can see one view parasternal, and one view is here apical, and one is at the subcostal. And this can tell you whether any of the chambers are dilated. It can also tell you whether the patient is in hypovolumic shock or not, because you can look at the IVC collapsibility. So these are something which I think this is ICOG can go in a big way and look at training in the point of care ultrasound of the obstetricians. So what it tells us about the left ventricle form and function. It tells us whether it's hypertrophied or not. It also tells us about pericardial effusion. At the pulmonary conditions, it can tell us about pulmonary edema, pneumonia, and pneumothorax. So all this can be made up just by one ultrasound sweep. So even ventricular ejection, you can, it has got an excellent overall agreement with echocardiography. So that means you can do an eyeballing, and you can know whether is it cardiac, is it pulmonary. So I think I'll leave out this on this summary and conclude by saying that breathlessness is a common symptom in pregnancy and is mostly physiological. It may be indicated, it may indicate some serious underlying cardiac or pulmonary pathology, which may be pre-existing or may be new. A thorough evaluation is warranted, especially if it is acute in onset, before labeling it as physiological. And it is important to understand whether primary pathology is cardiac or pulmonary. And detailed history and examination followed by CBC with peripheral smear, ABG, X-ray chest, coagulation profile, and ECG is essential for differential diagnosis. And radiation dose of most diagnostic tests present no substantial risk to the fetus. And recently the role of biomarkers, that is pro-BNP and also troponin test. If you think it is ischemic heart disease, there is chest pain, you can also do a troponin test. And the point of care ultrasound is emerging in acute cases. Thank you so much for patient hearing, and my apologies for exceeding a few minutes. Thank you.
Yes, thank you so much, madam, for that excellent presentation. Yeah, can we have the comments from chairpersons?
Yes.
I cannot see Subhash sir online. Can I request Bharti madam to introduce our next speaker? Ma'am, you can give the comments for the previous lectures. Neha ma'am.
Yes, indeed, it's a pleasure. And, listening to Madam Manju Puri, who has been managing the critical care cases day in and day out. And I'm sure all of you have attended her, sessions, especially during COVID times. What Madam has, formulated the GCPR for Foxy as well, Foxy ICOG. So we're really proud to have you, Madam, and really listening to you is always a pleasure. I'm sure the delegates have, benefited a lot from your talk. Thank you so much for accepting the invitation and presenting it wonderfully. Thank you, madam.
Sneha. Thank you.
Thank you so much. We can go to the next talk for Dr. Achila Batra. Do we have the chairpersons?
Bharti ma'am, can you please introduce Dr. Achila madam? Ma'am, you need to stop sharing your screen so that we can first display your CV slide, ma'am.
Bharti ma'am is requesting to unmute.
Okay. Nilima, can you please unmute her? We can't see her actually otherwise. Monica, if you can see her, please unmute.
Can I request Jignesh to please allow madam? Yes, ma'am. Ma'am, you.
Yes, Dr. Bharti.
Ma'am, you can speak. You've been unmuted also, ma'am.
Can you hear me?
Yes, perfect.
Yes,
Welcome,
ma'am.
Dr. Bharti.
First of all, yeah. Good evening, everyone. And as we all are here, and we are seeing that such a wonderful ICOG webinar series and on the especially emergency obstetrics. So we are having a very good topics. And next speaker is none other than Dr. Achila Batra. We all know that she's a good academic person as well as Foxian, dedicated, and National President NARSHI 2022 to 24, as well as Governing Council member ICOG, Chairperson SCP Division, ST Bus Society India, member Foxy Projects on Reducing Cesarean Birth, President NARSHI Delhi, also in 1921, President AOGD Foxy Delhi, as well as she has in her credits lots of publications, lots of awards, lots of textbooks. So now to Dr. Achila Batra for next topic. Dr. Achila, ma'am.
Thank you, Bharti, for the kind introduction. And is my slide visible?
Yes. Just make it full screen, madam. Slide show.
Okay. First of all, thank you, ICOG. Thank you, Sneha, for asking me to be part of this wonderful webinar and sharing the dice with so many stalwarts. So I would be talking about exacerbation of SLE during pregnancy. I will concentrate on definition of flare, diagnosis, differentiation of flare from other mimics, management, and how we can prevent if we can. We all know SLE is an autoimmune disorder characterized by antibody to nuclear and cytoplasmic antigens, causing multisystem inflammation, varied clinical manifestation, relapsing and remitting course. And more than 90% cases of LSE are in women, frequently starting at childbearing age. That is why with the advance in medicine, we see so many cases of SLE in pregnancy. It presents as constitutional symptoms alone, musculoskeletal, dermatological, renal, neuropsychiatric, pulmonary, gastrointestinal, cardiac, or hematological. The classical triad is fever, joint pain, and a rash. And once you have a patient like that, you go in for anti-nuclear antibody. If they're positive, then you see the history examination for constitutional sign symptoms and for biomarkers, anti-phospholipid antibodies, complement protein, and SLE specific antibodies, which are anti-double strand DNA antibody or anti-Smith. And if the score is more than 10, it is classified as 10. This is important to know because to diagnose flare of SLE in pregnancy is a complex process because so many signs, symptoms of pregnancy or pregnancy-related disorders like preeclampsia, sometimes infection, they mimic SLE and you may unnecessarily start treatment. You may not do the required treatment for the disease. So the flare can occur during pregnancy in the immediate postpartum period. Some studies say that the flares are more, while the others say it is same as general population. The reported incidence is 13.5 to 65%. But the risk of flare is more if the disease activity is there in the 6 to 12 months prior to conception, or if the patient has lupus nephritis. And when there is a flare, there is increase in maternal morbidity, preterm labor, and even fetal loss. So we need to ideally prevent flare, and if when they occur, catch them early and treat. There are certain risk factors for flare. If it is a long-standing SLE, the major organ disease is there, persistent clinical disease activity is there, immunological activities present, poor compliance to treatment, or patient has discontinued hydroxychloroquine, or has not taken the proper tapering of the immunosuppressive agents. So the flare can be constitutional, musculoskeletal, hematological, or musculocutaneous, which are more common, but severe flare involving organs can also occur, of which renal are the most common. What is a flare? A flare is an increase in activity which you may find by a score, or you have new symptoms of worsening disease, or when you assess the patient, you think the patient has more active disease and you need to intensify the treatment. But like I said, it is very difficult to make a diagnosis of flare because in pregnancy also the signs symptoms of pregnancy are like, symptoms of SLE. So a detailed history, targeted lab investigation, and with the markers of doing complements or antibodies can make a diagnosis. So in a pregnant patient, baseline test must be done in a SLE patient so that when she flares, you can find the difference from the previous test. And complements are not so helpful in pregnancy because they rise. So the decrease in level which is seen in SLE may not be obvious. But if there is a fall of more than 25%, then you can make a diagnosis of flare. Like I said earlier, that normal pregnancy can mimic a lupus flare. So the blood test will help you to make a diagnosis because the double strand DNA antibody will increase and complement will show a 25% drop. Then renal flares will be there if there's increase in serum creatinine, proteinuria, hematuria is there in the urine or cellular CAR. That is why in pregnancy, to catch a flare early, you have to do monthly tests for these patients for renal function and for checking urine routine for hematuria, cast, and proteinuria. Preeclampsia, which is more common in SLE, may present as an SLE flare. So you have to make a diagnosis in which the different shading point would be uric acid, which would be not so high in lupus, and the double strand antibody would be increased in lupus. Urine calcium would be increased in lupus. Thrombocytopenia, liver function test may be normal in SLE, but in preeclampsia, they may be elevated if it is HELP. And the markers like FLT PLGF ratio would be high in preeclampsia, which is now coming as a big way to make a diagnosis of preeclampsia, and it will be normal in lupus. Why it is important is because if it is preeclampsia, then you have to terminate pregnancy. If it is flare, then you have to make the treatment and need not terminate the pregnancy early. CNS flares are not very common. Maybe in 5% of the cases, diagnosis is very difficult because there are no localizing features. You have to do evaluation like any other brain pathology, doing brain imaging and doing CSF and EEG. And hematological flare are quite common in pregnancy. But again, anemia can occur in pregnancy because of various reasons. And thrombocytopenia also occurs, but this is physiological, not so much low as in SLE. And leukopenia also would be there. But then with anemia, we can have leukopenia, thrombocytopenia, as well as and which may be difficult to diagnose. So we will have to do the antibody test. And of course, the thrombocytopenia needs to be treated with pulses of IV methylprednisolone or immunoglobulin. And if the patient is refractory to that, then the thrombocytopenia need to be treated with rituximab, which is a newer monoclonal antibody. Infection in pregnancy can also, mimic a flare. So if you have a doubt, it's better to give IVIG as treatment for SLE than the steroid, because it will flare up the infection. Of course, there would be no response to antibiotic if it is a flare. There would be raised procalcitonin in infection, and in raised CRP would be there in infection and not in SLE. So that is why there are very validated instruments now has come from the European Society of Rheumatoid Diseases, and they say that you should do these activity index by giving weight to each symptoms and investigation, and then make the diagnosis, so that when there is a change in the index, you know it is a flare. So there are various index, and they classify mild, moderate, or severe flare according to the change in index. So once you have made a diagnosis of flare by whatever method, then you have to treat. The treatment is not much different than in non-pregnant, but there are certain drugs which we can't give, and steroid also have to be given at a lower dose. NSAIDs cannot be given after 20 weeks of pregnancy because they can cause oligoamnios, premature closure of patent ductus, GI bleeding, necrotizing enterocolitis, and intractable bleeding, hypertension, and prolongation of labor. Hydroxychloroquine is the mainstay of treatment for prevention of flare also. So if she's not taking hydroxychloroquine, you should start it, and you can increase the dose to 400 milligram twice daily from 200 if she's already taking and has a flare. When they are not controlled by the NSAIDs and hydroxychloroquine, then you have to give corticosteroid. And if she's taking, you have to increase the dose. If she's not taking, then you give 15 to 20 milligram of prednisolone daily, and you try to avoid giving more than 20, but you might have to give if the symptoms don't subside. Alternatively, you can give 100 milligram daily for 3 days, then you don't have to give daily maintenance dose. And if patient is anemic, then you have to give aggressive treatment and give IVIG besides corticosteroid for improving anemia and thrombocytopenia. Azathioprine is a drug which can be given as an adjuvant if the patient is not responding to steroid, and then you, and also by starting these drugs early, you can taper off steroid early and to a lower dose. The dose is not more than 2 milligram per kg, up to 1 to 3 milligram per kg is generally given. Other drugs, cyclosporin, can be used, especially in renal disease, because cyclophosphamide is a drug of choice for renal disease, which cannot be given in pregnancy. So cyclosporin can be given. It is safe for the fetus, though there is a little risk of maternal nephrotic toxicity. Tacrolimus, a calcineurin inhibitor, is 100 times more potent compared to cyclosporin, have recently been used and found to be good. IVIG, like I said earlier, for thrombocytopenia, you have to give, and for anemia. And newer agents like belimumab is not been studied much, but the data on animal is encouraging. And rituximab is a monoclonal Ig antibody, which is directed against antigen on B lymphocytes, and it has been used for the treatment and has been found to be good. Though still we are not, we don't have enough data, but refractory patient can be started with on these drugs. But mycophenolate and cyclophosphamide should be avoided. And the newer concept in the flare management is prevention. That is treat to target. That we should always keep the SLE in remission. And that is why you have those validated index. We should keep repeating them. And anytime you find a change in the index, you should start the treatment so that severe flare does not. And one should not treat asymptomatic patient just because we have serological findings. And quality of life is an important part. So if patient has fatigue, musculoskeletal problem, it should be treated. The renal involvement should be treated early because it can lead to end organ damage. And the hydroxychloroquine should preferably be continued during pregnancy in the patient of SLE that will prevent flare. And treatment should aim to give lowest glucocorticoid dosage to control the disease. And if possible, they should be withdrawn completely during pregnancy after the treatment of relapse. And if there is APLA, then of course, you have to reduce the morbidity by giving heparin. Or overall, that there is a general argument on the fact that you have to control disease activity with the achievement of remission, or at least should be considered as the main target to be reached in the treatment of SLE. And we have remission means the activity index, which are there, disease activity index 0 or global activity index less than 0.5, irrespective of serology. But it is not always possible to reach remission. So now we have another terminology, low level disease activity, which is possible to achieve, and the scores for which are little higher. But it is possible to achieve this low disease level so that the morbidity of the mother, the organ damage, and the fetal loss, preterm labor can be prevented when we keep the disease activity at a low level. So basically, the important thing for the flare of SLE is that you have to make a diagnosis. The rash of SLE from cloasma has to be differentiated. The proteinuria, renal disease has to be differentiated from preeclampsia. The thrombocytopenia of other causes has to be differentiated from SLE thrombocytopenia. And the joint involvement has to be differentiated from the pedal edema of pregnancy. And mild disease, glucocorticoids and hydroxychloroquine remain the milestone for early treatment in non-renal SLE. And when you're not able to get a remission fast, you should initiate the other agents like azathioprine early so that you reach your therapeutic goal and also decrease the duration of glucocorticoid therapy. In severe disease, you have to give higher doses of glucocorticoids. And once the patient shows clinical improvement, then you taper the disease. And if you can't taper, then you should start immunosuppressive therapy like cyclosporin, azathioprine. So prevention of severe flare is critical to ensure a better prognostic outcome for the patient. And these have been emphasized in this treat to target guidelines for SLE recommendation, in which you change the dose or give treatment at set intervals by doing the index, SLE index, so that you reach a well-defined target. And stabilization of disease and minimization of the flare should be a separate therapeutic goal which should be kept in mind. And we should always have try to have low disease activity or remission if you want to avoid flares, because once flare occur, early diagnosis and treatment of flare should be done. Thank you.
Bharti ma'am, over to you for your comments. Concluding remarks, please, ma'am. Sneha ma'am.
I think the chairpersons are not present here right now. So I would just conclude by saying that, Achila madam, very apt messages you have given about, the flaring up of SLE and when should she conceive in the, the period where the SLA is not active, and whether if it gets flared during the pregnancy, how we have to tackle. So thank you so much, madam, and thank you so much for accepting the invitation and for the excellent contribution as well. Thank you so much. Over to you, Monica. We can go ahead.
Thank you, Achula ma'am, and thank you, Bharti ma'am. I would now request Brijwala madam to please introduce our next speaker, Dr. Josna Suri madam. Brijwala ma'am.
Good evening, everyone. Thank you, Dr. Sneha, and for this wonderful webinar. I could join after some time, and I was not able to join because there were already 550 audience in this webinar. So it's your hard work and the selection of topic, Galaxy of Stars. So thanks for making me part of this. So without wasting time, it's my privilege to introduce Dr. Jyotna Suri madam. And madam is Professor, Unit Head, Critical Care Obstetrics, Safdarganj Hospital, Delhi. And she is Vice President, AOGD 2122, National Corresponding Editor, Jogi 2124. She had been Chairperson of Safe Motherhood Committee, Multidisciplinary Committee, and authored book Practical Approach. And she delivered more than 200 guest lectures and awarded.
Thank you, Doctor. Thank you, Dr. Brijwala. Can I share my screen?
Yes.
Permission? Yeah.
Thank you.
Yeah. So I'll just share my screen. Is it visible?
Yes. You can just make it slideshow. That's it.
Okay.
Right. Perfect.
Okay. So thank you for this opportunity, dear Dr. Sneha. I have been listening to the talks. They have been very high quality, and I think it's a treat for the PG students. And I'm really happy that you made me part of it, and I'm really honored by that. So the topic which I'm going to be talking today about is the, hyperthyroidism, basically the Graves' disease and thyroid storm in pregnancy. So without a background of the hyperthyroidism and Graves' disease, we cannot, just talk about the thyroid storm. So a little bit background about that, and then the critical condition of thyroid storm. So just to introduce the topic, in pregnancy, there is increase in the thyroid hormone binding globulin, which results in high serum total T4 and total T3. So I think students have to remember this very important physiological change, that if you do total T3 and T4, even in normal pregnant women, it will be much higher than what is there in the non-pregnant counterparts because of this. So that is why in pregnancy, we always go in for a free T4 or T3 concentration. Then second thing which I want to highlight is that high serum HCG concentrations in the early pregnancy, especially up to 14 weeks. So these, and especially, in women with multiple pregnancies, molar pregnancies, hyperemesis gravidarum. So these HCG concentration may be quite high, and they may result in transient subclinical or rarely overt hyperthyroidism. Then third thing is that when do we call a patient as overt hyperthyroidism? So it is defined by a low TSH, that is a suppressed TSH, we say, if it is less than 0.1 MU per liter, or undetectable if it is less than 0.01. So, this is the definition which is used, suppressed and undetectable. And along with this low TSH, there should be free T4 and or T3 level that exceeds the trimester specific normal reference ranges for that particular, trimester. So for pregnancy, there are trimester specific normograms, and it should exceed. Or if you do not have the facility for a free T3, T4, you can even take the total T4 and T3, but that should exceed 1.5 times the non-pregnant range along with the low TSH. So then we can call this patient as overt hyperthyroidism. Now, what is a thyrotoxicosis? So I want all the students who are listening to quickly write in the chat box, do they know the difference between hyperthyroidism and thyrotoxicosis? So if you know it, you can answer. Anyway, I'll briefly tell you that hyperthyroidism is when the thyroid gland is overactive and is secreting more thyroxine, whereas thyrotoxicosis is the presence of the thyroid hormone not just due to the hyperactivity of the thyroid gland, but also due to any other cause like tumors or like the iatrogenic, the external source of thyroid hormone may be there. So therefore, there is a subtle difference between these two conditions. Now, the commonest cause of thyrotoxicosis in pregnancy is Graves' disease, which is seen, in all these thyrotoxicosis, 90% are constituted by the Graves' disease. So what are the clinical features of hyperthyroidism? So many of these symptoms are non-specific and are associated with pregnancy, including tachycardia, heat intolerance, increased sweating. But there are some additional symptoms which can give you a clue, especially the tremors, weight loss despite a normal or increased appetite. And of course, if there are specific findings such as goiter and ophthalmopathy, then you can kind of clinch the diagnosis. So what is the, particular, risk if you are not treating the hyperthyroidism? So there are many, pregnancy complications which are associated. So right from first trimester, you may have the spontaneous abortion, the preterm labor may start, low birth weight, stillbirth, preeclampsia, very, very important complication, which is very often associated with hyperthyroidism, heart failure, and of course, the dreaded complication of thyroid storm, which I will talk about after a few slides. So now a case of overt hyperthyroidism comes to us. So how do we approach it? So the one question you have to ask, does the patient have any, all of the following, it will clinch your diagnosis. That is the new onset orbitopathy, large non-nodular thyroid, and moderate to severe hyperthyroidism. If answer is yes, your diagnosis is Graves' disease. If the answer is no, then you measure the TRAB, that is the thyrotropin receptor antibodies, which may be either the thyrotropin, the thyroid stimulating immunoglobulin, or the thyrotropin receptor binding inhibitory immunoglobulin. So both of these are part of the TRAB. So if she is antibody positive, again you are treating, dealing with a case of Graves' disease. If they are negative, then you should go in for a thyroid ultrasound to assess the blood flow. If it is high, it is a Graves' disease. If it is low, then maybe it is a case of thyroiditis. So now that you have made the diagnosis, do you treat all the cases? So many times you may refer your cases to the endocrinologist and they will not treat it. So they will just keep the patient under follow-up. But the treatment, indication of treatment is if the patient is symptomatic and if she has moderate to severe overt hyperthyroidism due to Graves' disease. So what is this moderate to severe? It means that the TSH values will be below 0.05 and elevation in the trimester specific free T4 and or total T4 and T3 that exceed 1.5 times the upper limit of normal for non-pregnant patient. So this will be the moderate to the severe, and along with that, she should be symptomatic. Now, what is the goal of treatment? The goal is to maintain persistent but mild hyperthyroidism in the mother in an attempt to prevent fetal hypothyroidism, since the fetal thyroid is more sensitive to the action of anti-thyroid drugs. So this is very important that when you are treating, you aim to keep the free T4 towards the upper normal level. Don't treat her to cause a fall of the T4 to the mid or the low range, which will result in hypothyroidism in the baby. So over treatment of maternal hyperthyroidism with thionamide antithyroid drugs can cause fetal goiter and primary hypothyroidism. Very important thing for all of you to remember. So what are the therapeutic options that you have? The first is that you decrease the thyroid hormone secretion. So the drug of choice, you know, thionamides are the first choice of treatment to decrease the thyroid hormone synthesis. And both methimazole, carbimazole, as well as the propyl thiouracil cross the placenta with equal transfer kinetics and have similar effects on the fetal thyroid. So all these drugs, you know, they cross the placenta freely. So now which one do you choose? In the first trimester, it has to be propyl thiouracil always, because the methimazole or carbimazole can cause a very specific anomaly in the first trimester, which is called the aplasia cutis. But other more serious, anomalies which it can cause are the TOF and the omphalocele. So these are the other more serious anomalies besides the specific anomaly of aplasia cutis. So we never give it in the first trimester. However, PTU, of course, is that way safer. It can cause minor anomalies, but doesn't mostly cause the major anomalies. But it can cause severe hepatotoxicity in some patients, and that is seen mainly in the first 60 days of the treatment. So these are the things which you have to be careful about when you are prescribing or when your patient is taking these drugs. Now, what are the doses? The PTU is given as 50 milligram 2 to 3 times daily in a stable patient. But in severe cases, it may go up to 100 milligram 2 to 3 times. And methimazole is 5 to 10 milligram. In severe cases, 10 to 30. Carbimazole 5 to 15, and severe cases 30 to 60 milligram every day in divided doses. The other therapeutic option is symptomatic treatment. So your patient is having symptoms like tachycardia, severe. The patient may say, she's very heat intolerant, she's having ghabrahat. So that is the time when you need to act very fast. So beta blockers can be given to ameliorate these symptoms immediately. You can start with metoprolol or propranolol 20 milligram every 6 to 8 hours until, of course, we start this along with the thionamides, and then we may stop it after about 2 to 6 weeks once the action of the thionamides has started taking place. So we can stop these drugs. So now when your patient is on these drugs, monitor the patient, the TSH and free T4 monthly. Keep the free T4 at upper normal range to prevent hypothyroidism in the fetus. Measure the TRAb, antibodies in all women on thionamides. The serum thyrotropin antibodies should be measured at diagnosis, and if elevated, again at 18 to 22 weeks and at 30 to 34 weeks. Disappearance of these antibodies indicate potential remission of Graves' disease, and the dose of thionamides can be now reduced and potentially discontinued in the third trimester. High TRAB levels in late pregnancy are associated with an increased risk of fetal and neonatal hyperthyroidism. So again, it can, if these antibodies are high in the late pregnancy, we have to monitor the fetus also for neonatal hyperthyroidism. So some women who are intolerant to thionamide, there is one very dreaded complication of agranulocytosis. So even though it is rare, but if it takes place, then these women cannot be given any thionamide, whether it occurred with PTU or with methimazole or with carbimazole. We cannot give her any thionamide, and in these cases, the women will have to undergo the surgery. That is, the thyroidectomy is the best option after giving a short course of the beta blocker. Radioiodine for pregnant women is absolute no. Okay, so hyperthyroid, this is contraindicated both in pregnancy and in the lactation. Course of Graves' disease, it spontaneously improves in the third trimester, typically worsens in the postpartum period. and sometimes may present first time in the postpartum period. And when new hyperthyroidism occurs in the first months after delivery, it may be either Graves' disease or postpartum thyroiditis. Of course, then you need to treat it and monitor the patients. And fetal and neonatal hyperthyroidism, all fetuses of women with Graves' disease should be monitored for signs of fetal thyrotoxicosis by determination of fetal heart rate and assessment of fetal growth. If the fetal thyrotoxicosis is suspected, prenatal thyroid ultrasound should be done to rule out fetal goiter, but routine fetal blood sampling should not be performed in women with Graves' disease. Breastfeeding, these women are, both the drugs are kind of safe if, it is given in the moderate doses, and radioiodine therapy should not be given. Now, thyroid storm, quickly, few slides. You have already got the background now of what are the drugs we are using and, how we diagnose and treat the hyperthyroidism. The hypothesis includes a rapid rate of increase in serum thyroid hormone levels and increased responsiveness to catecholamines or enhanced cellular responses to the thyroid hormone. The total T3, T4 may be similar to that seen in uncomplicated patient, but the free T4 and or T3 levels may be higher. So the thyroid storm can also be defined as an acute exacerbation of hyperthyroidism, which has a life-threatening, condition with a 25% mortality. Hypermetabolic state, which is rare in pregnancy, but if it occurs, it can be, as I told you, life-threatening. 1 to 2% of hyperthyroid patients may get this, thyroid storm. And the classic features are fever more than 104, nausea, vomiting, diarrhea, dehydration, tachycardia more than 140 with atrial fibrillation in more than 60% cases, palpitations, arrhythmias, high output cardiac failure. ENS is again a very typical, patient may have psychosis, agitation, delirium, jaundice, abdominal pain. So all these are very important things which you can see. Precipitating factors in pregnancy, especially preeclampsia, anemia, surgery, so cesarean section, and as well as normal labor, and a withdrawal of the anti-thyroid drugs. Lab values, you will have again increased T4, T3, low TSH, increase in TLC, transaminases will be increased, hypercalcemia, and again, because of the high steroid, catecholamine levels, the hyperglycemia can be there. So this is one important score because it's a clinically diagnosed condition. So these scores have been, propagated for timely diagnosis of the condition. You can take the picture of this. So a score more than 45 is highly suggestive of thyroid storm, and 25 to 44 supports the diagnosis, but below 25, the thyroid storm is unlikely. And general principles of management: beta blocker to control the symptoms, thianomide to block the new hormone synthesis, iodine solution to block release of thyroid hormone, but start it after 1 hour of thianomide to prevent iodine from being used as substrate for new hormone synthesis. An iodinated radio contrast agent to inhibit the peripheral conversion of T4 to T3, but again in pregnancy we will not use it. Glucocorticoids to reduce T4 to T3 conversion, and they also promote vasomotor stability, as well as, they can treat the relative adrenal insufficiency. And in some cases, even cholestyramine has been found to be useful because it decreases the enterohepatic recycling of thyroid hormone. So these are the drugs which I have just told you about. You can give very high doses of thianomides like PTU from the NG tube also, and sometimes even rectal suppositories can be given. Beta blockers, again, propranolol IV 1 to 2 milligram over 5 minutes can be given, but if the patient can take through orally or NG tube, you can give a 40 milligram stat and then repeat it 6 hourly. And the corticosteroids, I already told you, 100 milligram IV 8 hourly. So this case came to us, in our antenatal OPD, and she was already diagnosed as a Graves' disease. She came with high BP. This was the goiter which she had. She was already on carbimazole 50 milligram per day, but she had, she used to be skipping her medications in between. So when she was admitted with high BP, all her investigations were done, which were found to be within normal limit, but the fundus showed grade 1 retinopathy. Her, you can see anti-TPO was high, TSH was always less than 0.01, and free T4 and T3 were also high. So when we had admitted her, we found her, that she was also having FGR, and she was started on labetalol. BP got controlled, but after 3 days, we had to induce her because of persistent headache. She was already on carbimazole, as I told you, 50 milligram per day. So the patient had emergency cesarean due to fetal distress, but on day 3, she developed sudden onset breathlessness, difficulty in breathing and palpitation, and had one episode of vomiting. Pulse rate 140, temperature 102, BP 130, 100, SpO2 95%, and bilateral V. So we made the diagnosis of thyroid storm. The score, which I just told you, it was 75 in this patient. And she was managed by these, measures: immediate injection, hydrocortisone, propranolol, 40 milligram stat, oxygen, IV infusion of PCM for hyperpyrexia, and carbimazole dose was also stepped up. ECG was done, which showed, the echo, was done, which showed mild MR and TR, and EF was 55%. So the patient, after all the measures, she improved after 48 hours, and then we discharged her after stitch removal on carbimazole 50 and propranolol 20 milligram BD. So the key points for this talk of Graves' disease and the thyroid storm is that Graves' disease is the most common cause of hyperthyroidism in pregnancy. PTU is the drug of choice in first trimester, as methimazole has more teratogenicity. Methimazole or carbimazole may be used in the second or third trimester. Goal of treatment targets the free T4 in upper normal range to prevent fetal hypothyroidism. Beta blockers are the mainstay for symptom control, and thyroid storm is precipitated by labor, delivery, and cesarean section. So be very cautious if you are treating a case of Graves' disease. You are delivering her. You have to be very, very cautious about thyroid storm. And mainstay of treatment for the thyroid storm is beta blocker, thianomides, antipyretics, corticosteroids, and iodine solution. Multidisciplinary involvement of physician, cardiologist, endocrinologist is required along with the obstetrician. So that's the end. Thank you very much for the patient hearing. And I think I did overstep by 2-3 minutes, or 5 minutes rather, it has come now.
Thank you, ma'am. I request Brajmala ma'am to please conclude madam's talk and also introduce our next speaker, Dr. Aparna ma'am.
It was excellent talk, and I think it is though rare but not uncommon disease. And nowadays we come across people comes with the pregnancy, and there are many times we confuse with the symptoms of physiological changes of pregnancy, and we need to understand all the storm and the when to use the beta blockers and corticosteroids, and the particular use of PTU in first trimester and methimazole in second trimester, and that score was excellent. I think that was very, very going to very helpful in our day-to-day practice. Thank you so much, ma'am. It was excellent talk.
You can also introduce Dr. Aparna Sharma.
Yeah. Monica, can I have the, yeah. Thank you. So it's my privilege to introduce Dr. Aparna Sharma, madam. Madam is MD DNB, and she's professor in AIMS, and she is a specialist in fetal medicine, secretary of Society of Fetal Medicine 22-24, and she had been chairperson multiple pregnancy committee, Stillbirth Society of India, and chairperson of AOGD Quality Committee, Zone coordinator for Safe Motherhood Committee, co-convener in early pregnancy SIG Indian Fertility Society, and she had delivered many orations, and she had been awarded with Foxy Junior Korean Award in 2018, Sun IEC International Traveling Fellowship, Legends of Tomorrow Award, Imaging Science Committee Award, Rajat Ray Award, and many more. So without wasting my
It's time. I request Dr. Aparna Sharma Madam to go ahead with her talk on VT in pregnancy, ma'am.
Thank you, ma'am, for the kind introduction. And thank you, Sneha, ma'am, for having me here. And I think I've heard the previous speakers and we've had a very nice academic session going on. Great attendance here. So the topic here is VTE in pregnancy, venous thromboembolism in pregnancy. It's a very challenging topic, so to say. So if we want to really understand the topic, I think it would be a good practice, or it would be a good way to talk about this in three different aspects. When should we anticipate VTE? When should we, think that, okay, this woman might have VTE? When do we suspect that, okay, she is having VTE? And if she is having VTE, when should we treat, how to treat VTE? So we would be taking this talk over the next 15 minutes in these three aspects. Now, I would request the students to look at this case scenario, put your answers in the text box. We'll come to this case scenario in the end again. This 30-year-old lady who's 32 weeks pregnant, she's heterozygous for factor V laden. She has no personal history, but her mother has a history of unprovoked VTE. She has no other risk factors or medical history, and she's referred to you for counseling regarding the role of thromboprophylaxis. So what would you do? Think about it, put your answers in the chat box. We will come back to the scenario and discuss if what you have thought is correct. In the second scenario, she's a 25-year-old lady who had an urgent unplanned cesarean in the night because of failure of progressive labor. Her cesarean delivery was uncomplicated and with an estimated blood loss of 750 ml, should the patient receive postpartum thromboprophylaxis. Now, to talk about VTE, we know that pregnancy is a high-risk situation. Risk of VTE in pregnancy is 5-fold, while that in postpartum is 30 to 60-fold. Deep venous thrombosis is more frequent during pregnancy, and pulmonary embolism is more likely in the postpartum period. But the question remains that why does it happen more in pregnancy and postpartum? So we know the classical triad of endothelial injury, abnormal blood flow, and hypercoagulability. Thus, venous stasis and delivery may contribute to the endothelial cell injury. The compression of the pelvic veins and IVC by the enlarging uterus leads to the abnormal blood flow, and the hypercoagulability is the change in the coagulation system which happens during pregnancy, which is actually a prophylactic mechanism to control the blood loss which happens during delivery, because of which your fibrinogen, the factor 7, 8, 10, VWF, and all of it is increased. So these changes, all of them predispose our women to having VTE. So the question remains that which are the women who are more prone to having venous thromboembolism in pregnancy? So to put it in another way, which are the risk factors? So before we come to the risk factors, when should you actually do the risk assessment? So we should do the risk assessment at every possible time, which is to say in early pregnancy, pre-pregnancy, repeat it if the woman is admitted to the hospital for any reason, or repeat again in the intrapartum or immediate postpartum period. So the risk factors can be divided as some of the pre-existing risk factors, the obstetric risk factors, or the transient risk factors. So the pre-existing risk factors, and each of them is given a score. So we know that this is an RCOG scoring system. So if you have a previous venous thromboembolism, you give a score of 4, which is a high score. So there's a previous venous thromboembolism which is provoked by a major surgery. So this is a provoked, so the score becomes less. Known high-risk thrombophilia, you have medical comorbidities like SLE, inflammatory bowel disease, sickle cell disease. So you give a score of 3. Family history of unprovoked VTE in the first degree relative. So there's a family history of inherited thrombophilia. You give a score of 1. Known low-risk thrombophilia, you give a score of 1. You have an age of more than 35, obesity, parity more than 3, smoker, or gross varicose veins. So these are low risk factors, but they do contribute to risk factors. So all of them are given a score of 1. So these are pre-existing risk factors which you can assess at the time that the woman has come to you in pregnancy. Then there are other obstetric risk factors like preeclampsia, ART, multiple pregnancy, emergency cesarean section in labor is given a factor of 2. The other things being prolonged labor, PPH of more than 1 liter becomes 1. If it is less than 1 liter, you don't count it into any factor. Then preterm birth, stillbirth in current pregnancy. Then there could be other transient risk factors like any surgical procedure in pregnancy, puerperion, except immediate repair of the perineum, hyperemesis, dehydration, OHSS in the current systemic infection, immobility. Patient is lying down. OHSS, you see, you're giving a mark of 4. So the OHSS is a high risk factor for VTE. So all of these risk factors. So it is not that you have to remember everything, but these things are there so that, you need to go back to these scoring systems so that we are able to assess. So if the total score is antenatally more than 4, then we need to consider thromboprophylaxis from the first trimester itself. If the total score is 3, then thromboprophylaxis can be considered from 28 weeks onwards. If the score is more than 2 postnatally, then it can be considered for at least 10 days. And if admitted to hospital antenatally, then admission, because it would entail that, the patient is not very mobile, then we can consider thromboprophylaxis. And if she's readmitted to the hospital in the puerperium period, then again consider thromboprophylaxis. So this is what the RCOG guidelines say. So you see, these are the high risk factors. We need to consider antenatal thromboprophylaxis. In the intermediate risk, consider antenatal thromboprophylaxis like we discussed, high risk thrombophilias, medical comorbidities, OHS in the first trimester. Again, if you have the other risk factors, we need to have a combination of risk factors. If you have 3 or more, prophylaxis from 28 weeks. If you have 4 or more, you consider prophylaxis from first trimester itself. If it is not, all of these things are not there, then you are in the low risk factors and you don't need to consider prophylaxis. So high risk thrombophilia that we are talking about is antithrombin deficiency, protein CS deficiency, homozygous for factor V laden, and homozygous for prothrombin gene mutation, while the low risk thrombophilias are heterozygous for factor V laden and prothrombin, some other prothrombin gene mutations, and antiphospholipid antibodies. So these are some of the things that we should consider. Again, for postnatal thromboprophylaxis, we need to understand that if you are in the high risk situation, we need to give it for at least 6 weeks in the postnatal prophylactic LMWH. And in the intermediate risk, we give it for 10 days. But if it is in the lower risk and we have ruled out the other things, then you can not give prophylaxis for venous thromboembolism. So there are the guidelines. If we want to summarize, we need to talk about few things. That if you have a prior history of venous thromboembolism, we need to give low molecular weight heparin for prophylaxis. But if there is no prior thromboembolism, previous history of thromboembolism, we need to see if the patient has a high-risk thrombophilia, then we can consider prophylactic low molecular heparin. But what is important is that most of our women will neither have previous history of VT or any history of thrombophilia. So this is our majority of patients. So in such situation, if there are more than 3 risk factors, then we can consider prophylactic low molecular weight heparin. If there are less than 2 risk factors, then we can consider low molecular weight heparin in the later half of pregnancy or postpartum period. Or if there are less than 1 or 1 risk factor, then think of only clinical vigilance. So this is something that we can remember. If there is no VTE, no thrombophilia, look for risk factors, 3 or more risk factors, prophylactic low molecular weight, less than 2 or more, maybe later on prophylactic, and if it is 1 or less, only surveillance to be remembered. So these are something which even the ACCP guidelines talk about, that most of our women will not have VTE, neither thrombophilia. So only follow surveillance. But if there is VTE, then you give prophylactic. If there is no VTE, but high-risk thrombophilia, then we need to give prophylactic intermediate dose low molecular weight heparin. So that is something that we need to remember. One thing is that we are talking so much about thrombophilia. So when do you actually screen for thrombophilia? You need to screen for thrombophilia when you have previous unprovoked venous thromboembolism. It is then that you screen for thrombophilia. Or you have a family history of unprovoked venous thromboembolism.
There is no reason to screen for thrombophilia when you have a bad obstetric history or a known SLE. In that situations, there is no need to screen for inherited thrombophilias. Only when there is a thromboembolism that you start screening. So there are certain risk assessment calculators, like you can look into some of the internet, you will find free risk assessments calculators like this, in which you can enter your previous risk assessed existing risk factors, obstetric risk factors, transient risk factors, and it will give you a final risk assessment score, and it will tell you overall score is this, and you should offer thromboprophylaxis for 6 weeks. So it's a very simple calculators that are available, which will based on the RCOG guidelines, which can provide. Now, the second part is, I'm almost 9 minutes through the talk, so I will quickly talk about the next part is, when do you suspect VTE? Now, that's a very important thing. First is that we need to understand that deep venous thrombosis will predispose to pulmonary embolism. So diagnosis is in pregnancy of DVT, mostly in general population, it would originate in calf. But in pregnant women, it is mostly in the iliofemoral vein. So we can miss it in pregnancy. So what happens is, left leg is the most common site for venous thrombolism in pregnancy. It is obviously because of the compression of the left iliac vein. Now, Homan sign has to be demonstrated, but it lacks specificity in the pregnant women because of course, because of the changes of pregnancy. But if there is massive DVT, it is then that you will find the typical signs of the white leg, which is the milk leg, or the edema, pain, cyanosis, and the occlusion. So this is very rare, but it is in pregnancy, it is very, very challenging because it might interfere with your pregnancy changes, might interfere with your changes of DVT. So you can't rely really on the clinical signs and symptoms. Now, pulmonary embolism, what is happening is that when there is a DVT, it dislodges, it obstructs the pulmonary vasculatures, it leads to hemodynamic instability. So because you're not able to rely on the clinical signs, you have to rely on the investigations, which include your duplex ultrasound, compression ultrasound, chest X-ray, ECG, ABG, CTPA, and VQ scanning. Now, compression ultrasound is actually the primary diagnostic test in which the whole venous network is scanned. And what really is happening is that if there is a DVT in this vein that you can see here, because of the clot, the normal vein will get compressed and the clot will not get compressed. However, it is difficult sometimes in pregnancy because difficult to evaluate an iliac level in pregnancy. And because of the technical difficulties, it may not be a very good investigation in pregnancy. Chest X-ray, of course, if it is a massive event, then you can find features like atelectasis, effusion, opacities, so that you can find. ECG and ABG, typical findings, if you have a massive event, you can find hypoxia, hypocapnia on ABG. ECG abnormalities can be seen in 41%. Then, of course, you have the CTP and the VQ scan. For all practical purposes, there is only CTP, and now VQ scan is not being done too often. The use of D-dimer in pregnancy is limited because of the physiological increase. However, according to the threshold, from 94%, the cutoff of 500 to 90% cutoff of 1000. Now, there are certain situations where you can use the D-dimer, but it has to be used very, very intelligently. So if you are suspecting a pregnant patient, I will be discussing certain flow charts, and there are certain, useful ways in which you can use these flow charts. So you do a compression ultrasound. If this is positive, you start management for DVT. Now, if it is normal, but you suspect an iliac vein thrombosis, you need to investigate further using some MR venography, CT venography. If it is not available, it is advisable to do serial compression ultrasound on day 3 and day 7. If it is equivocal, then you need to do a D-dimer test. If it is positive, we also need to repeat. So basically, it is believed that single compression ultrasound may not be very beneficial, but it is important to do a serial compression ultrasound. And if it is serially negative, then it rules out a DVT. Then if you are suspecting, if it is a normal, compression ultrasound is normal, then there is something called a Ears algorithm or a Geneva score. Now, Ears algorithm is tested. This was a paper recently which has got published in the Lancet, that if you have clinical signs of deep venous thrombosis, hemoptysis, along with, you think that pulmonary embolism is the most likely sign, then you do the D-dimer. If there are no criteria of the years criteria and the D-dimer is less than 1000, then unlikely that there is pulmonary embolism. But if, however, if you have a criteria of the years criteria along with a D-dimer which is more than 500, so in that case, you can do a CTPA and corroborate your finding. So D-dimer is a useful test when you are corroborating that with the clinical signs and the possibility of a symptom, clinical signs and symptoms, and you are a strong possibility. So in isolation, D-dimer may not be useful, but when you are corroborating that with a ultrasound, like in this particular case, if you have the possibility, a clinical possibility along with a D-dimer which is positive, and you're joining that with an ultrasound which is positive, then you are strongly suspicion that you have a pulmonary embolism. So it's important to understand that it's not possible for everybody to do a CTPA scan, but if you have a combination of a clinical test, a D-dimer, and an ultrasound which is suggestive, then it is strong suspicion of a pulmonary embolism and we must start treatment. So that is the whole algorithm for diagnosis. If you have leg symptoms which are present, do an ultrasound. It is positive, you treat. If the leg symptoms are absent, you do an ultrasound, chest x-ray. If it is abnormal, you go for a CTPA. If the CTPA is positive, you treat. If it is CTPA is negative, you stop. In the absence of CTPA, like we discussed, if the ultrasound is suggestive, the D-dimer is suggestive, the clinical signs are suggestive, you have to treat. So treatment is more important and then not to treat, because it's that vital period when you have to start treatment. Now, in the last part, we discussed how do we treat VTE. So it's actually antenatal risk assessment, initial treatment with heparin, then certain specific condition where you have a massive life-threatening PE, and antenatal coagulation during labor and delivery. So we know that the treatment is with heparin. Before we start, a complete hemogram, coagulation screen, kidney function test should be performed. We know that thromboprophylaxis for is when you are suspecting a DVT, we need to give the initial enoxaparin is based on a therapeutic dose. For a 50 to 60 is 60 milligram twice daily or 90 milligram once daily. Or if the patient is more than 70 kgs, you give 80 milligram twice daily or 120 milligram once daily. I think this is the standard dose once we have to remember. So this is a therapeutic dose of enoxaparin for a patient in whom you are suspecting therapeutic regimen of DVT. Unfractionated is preferred in the peripartum period when you have an impending delivery, when you have to stop the heparin, and there is an increased risk of hemorrhage and you're planning a cesarean section or a delivery. And also when you have a renal impairment of GFR of less than 30 ml per minute, then in that case, it's better to avoid LMWH and give unfractionated heparin. We know the difference between LMWH and unfractionated. Most importantly, there is an antidote for unfractionated. There is no antidote for LMWH. So when we are in a situation where we might have to stop heparin, it's important to give unfractionated. However, in the long run, it's better to give low molecular weight heparin. Unfractionated heparin, we have to give 10,000 units subcutaneously every 12 hours, adjusted to a target APTT in the therapeutic range of 1.5 to 2.56 hours after injection. There is no need for monitoring the low molecular weight heparin. Low molecular weight heparin is stopped 24 hours if you're giving therapeutic before C-section or induction of labor, and unfractionated is stopped 12 hours and 6 hours before induction of labor, and given 4 hours post-operatively, treatment dose 8 to 12 hours later. Low molecular weight not to begin for at least 4 hours after catheter has been removed, and catheter should not be removed within 12 hours of the most recent injection. Now, women should be offered a choice postnatally whether to give low molecular weight heparin or anticoagulation. And this is the most important point, is that postpartum warfarin should be avoided at least till day 5 because of the risk of hemorrhage, hematomas, bleeding, requiring secondary secondary surgeries for bleeding. So women should be advised, and both of them can be given in breastfeeding. These are, if there is a resistance to heparin, there are other second line drugs like danaparanoid, which is safe during breastfeeding. or Fandaparinox. All of them are given in breastfeeding, but they have not been found to be very safe in pregnancy with limited experience in pregnancy, but they are given if there is resistance to heparin or alternative anticoagulant prophylaxis is needed. Warfarin, of course, we are giving following delivery in breastfeeding mothers when we have to continue it for 3 months postpartum. Generally not appropriate when you are giving only for 10 days postpartum. Now, low dose aspirin is not recommended. Dextran should be avoided antenatally and intrapartum. Other 10A inhibitors like dabigatran we have used, especially when there is resistance to heparin or not getting adjusted to warfarin. There are certain situations where there could be massive life-threatening PE, which is defined as sustained hypotension requiring inotropic support, pulselessness, persistent profound bradycardia. In that case, there is a loading dose of 80 units per kg followed by continuous IV infusion of unfractionated heparin that needs to be given, followed by a maintenance dose 6 hours after any dose, mandatory to measure APTT level and maintain the therapeutic level between 1.5 to 2.5. So once there you have, is there any role of thrombolytic therapy? This is rather controversial. There are only 3 indications for thrombolytic therapy. If you have acute pulmonary edema with hypotension, but no high risk of bleeding, so then you have a thrombolysis recommended. But if you have acute PE, but no hypotension, then the thrombolysis is not recommended. But if you have acute PE and you have given anticoagulation and there is deterioration, but there is no hypotension plus low risk of bleeding, then you can consider anticoagulation. So this is something which is thrombolysis has to be given under full precautions in consultation with your hematologist, because there's a lot of controversy around it, still case reports around it. So recommendations are based only on case reports. So coming back to our case scenarios, I don't know if there are any answers in the chat box. She's a 30-year-old lady, heterozygous. So if we see, she is a low-risk thrombophilia. So she's a low-risk thrombophilia and she has no personal history, but there's a family history. So her score is 2. So based on that, she would need postpartum prophylaxis for 10 days. And ACOG what says is that she is a low-risk thrombophilia without a previous VTE. So antenatally, she would require only surveillance. However, if the patient has additional risk factors, which in this case would be a first-degree relative with a history of thrombotic episode, in that case, you can consider a postpartum prophylactic anticoagulation therapy. So both RCOG and ACOG agree on this case that she would need a postpartum prophylactic therapy for 10 days. So I think so it's very easy that way, that even if you corroborate both the things, you will agree to that. And an urgent unplanned cesarean delivery. So you see the final score here is that an emergency cesarean section has a risk score of 2. So if when you have a risk score of 2, this advises a postpartum LMWH for 10 days. So that is the answer. And the ACOG says that if this patient has any antepartum, of course, you will not give. But if this patient has any risk factors, like say, for example, here it is not mentioned if she's obese or any other risk factors, then in that situation, you can give her a postpartum anticoagulation. So more or less, if you just follow the step-by-step approach to assessing the risk factors at every step, then you can answer the questions nicely and manage the patients nicely. So to conclude, this was a very beautiful article on how a consensus bundle on venous thromboembolism. So we need to have a readiness for every unit, use a standardized thromboembolism risk assessment tool at the first visit, all antepartum admission, immediate postpartum, on discharge to identify the patients at risk of VTE. We need to have recognition and prevention for every patient. So apply standardized tool to identify appropriate patients and provide patient education. So use scoring system to decide whether pharmacological prophylaxis is needed. The third point is response is needed. For every unit, standardized recommendation from mechanical thromboprophylaxis and for dosing of prophylactic and therapeutic pharmacological anticoagulation. So once a DVT happens, once a PE happens, we need to institute proper pharmacological anticoagulation, consider recommendation from current guidelines for appropriate VTE prophylaxis based on risk factors, and reporting and learning, review all thromboembolic events for system issues, learn from failures, realize if and where the improvement was needed. So thank you very much.
It was excellent talk, madam, because nowadays VT is not only the disease of Western world, and you have covered everything from risk factors to assessment and how to go along with investigation and what to follow. It was excellent elaborated talk, and it's need of time now. Thank you so much.
Thank you so much, Dr. Aparna, for accepting our invitation and wonderful presentation. Very, very comprehensive and, very excellent as far as even the practical aspect is concerned. Your case scenarios, the way you explained to the PG students, that was really wonderful. I'm sure even it was helpful for the practicing obstetricians and gynecologists as well. Thank you so much, Dr. Aparna. And immediately now we will go ahead with the post test. So yes, you can start, Poonam. You can post the post test here.
Yes, ma'am. Gauri?
Yes, ma'am. Yes.
Yeah, I think the time is up.
Yes, so the time is up. Poonam, can you share the answers so that we can read out fast?
Yes, ma'am.
Yeah. So thank you so much, all the faculties and the chairpersons. If you can just enlarge, zoom it for me. Yes, Poonam, can you zoom it?
Yeah, madam, doing.
Yeah. Okay, should I start reading? Which of the following is the first line drug for hypertensive emergency in pregnancy? Oral nifedipine, IV labetalol, IV hydralazine. The correct answer is all of the above. What is not included in the definition of hypertensive crisis in pregnancy? Acute severe persistent hypertension with BP more than 160/110, high BP lasting for more than 15 minutes associated with end organ damage. So acute severe persistent hypertension with BP more than 180/120, that is not included. In PIH, an impending sign of eclampsia is visual symptoms, okay, not weight gain, severe proteinuria or pedal edema, but visual symptoms. Which of the following antihypertensive drug is not safe in pregnancy? That is enalapril. Which type of eclampsia has the worst prognosis? The antepartum eclampsia, definitely. Question number 6, cause of convulsion in eclampsia is the cerebral anoxia due to arterial spasm. Right. Next. So which of the following statements is incorrect in relation to the pregnant woman with epilepsy? First is the rate of congenital malformation is increased in offspring of women with epilepsy. Seizures, wait. The correct answer is seizures frequently increases in approximately 70% of women. That is the correct answer. Which of the following statement is incorrect? So the answer is this, but this statement is incorrect. Next. 8. Status epilepticus occurs in following percentage of females during pregnancy. That is, the answer is 1 to 2%. Danger signs in breathlessness in pregnancy are all of the following except associated with ankle swelling. So this is not a danger sign. 10. Causes of dyspnea in pregnancy. They are all of the above. That is the answer. That is increased mechanical load by gravid uterus subject to awareness of hyperventilation, upward displacement of the diaphragm. Then comes in a patient presenting sudden onset breathlessness and pleuritic pain, collapse, most common diagnosis will be pulmonary embolism. Next, 12. Yes. In addition to the risk of major congenital malformation, which of the following anti-epileptic drug is also associated with an elevated risk of autism spectrum disorder and lower IQ at age 6? That is valproate. Which anti-epileptic drug is comparatively safer during pregnancy? That is lamotrigine. Which of the following in the treatment of choice for venous thromboembolism in pregnancy? That is low molecular weight heparin and unfractionated heparin. Which of the following drug is not used in medical management of ectopic pregnancy? Misoprostol. In which of the below situation, medical management of ectopic is contraindicated? That is presence of fetal cardiac activity, fetal heart activity. Ectopic pregnancy is best diagnosed by transvaginal scan. That is the correct answer. 18. Graves' disease is the most common cause of hyperthyroidism in pregnancy. True. The drug of choice for Graves' disease in the first trimester is propylthiouracil, PTO. Common features of thyroid storm include all except hypoglycemia. The goal of treatment of Graves' disease is keep free T4 in the upper normal range, not lower than this. 22, Graves' disease. It has a spontaneous remission in the third trimester of pregnancy. That is the characteristic of this, which is not required for the diagnosis of pregnancy-induced hypertension. So nowadays, this is the proteinuria. Previously, we have hypertension, petrolidemia, and proteinuria. So proteinuria is not necessary now for diagnosis, which is not at risk for, not a risk factor for preeclampsia. That is multigravida. Next. Which statement is not true with regards to preeclampsia? It is due to a state of fluid overload. The edema may be generalized. The correct answer is the proteinuria often occurs after the edema and hypertension, which is not accurate with regards to management of eclampsia. Magnesium sulfate does not lower BP. Okay. 27, which would be consistent with a seizure due to eclampsia. It responds to benzodiazepines. 28, the pregnant patients with systemic lupus erythematosus should be tested for A and B both. Okay. 29, the incidence of ectopic pregnancy in artificial reproductive technique is 5%. The incidence of ectopic pregnancy in ART, 5%. The mesenteric side of tubal ectopic rupture leads to frank hemoperitoneum, broad ligament hematoma, tubal abortion or shock, that is broad ligament hematoma. So, what is that? Please explain question 26. Can you, Poonam, can you just for a second, please once again share screen? 26. Yeah, so just little down. Yeah. Which is not accurate with regard to management of eclampsia. So seizures are usually self-terminating in left, if left untreated, but will recur. This is correct. Magnesium sulfate 4 grams should be given over 15 minutes for seizures control and then infused at 1 gram per hour. This is also correct. The desired BP is a diastolic blood pressure of 90 millimeter of mercury. This is also correct. Magnesium sulfate does not lower BP. This is not correct because this does have some central effect of lowering blood pressure, though this is not an antihypertensive. Okay.
Yes, patient will need a separate antihypertensive. That is why this is
We
the
don't
right.
have to discuss that. Only doubt she had is magnesium sulfate does not lower BP, whether this is. So this is not true. This statement is not true because it does lower the blood pressure. Okay, I think the doubts are cleared now. Right. Thank you. So thank you, Poonam. And over to you, Parag, just to say a few words for concluding.
Right. Thank you, Sneha. First of all, I must compliment you for thinking of this program and arranging it. Of course, the entire team who's working very hard with you, sitting in front of laptop for 4.5 hours is not easy. Hats off to you all. All the speakers were really good. They were all experienced people and their presentation had a lot of take-home messages. There are quite a few queries in the audience. Now, all these programs will obviously be put up on the ICOG website. So at a later date, do visit ICOG website www.icogonline.org and you'll get to see all the certification programs. Of course, you will not receive a certificate if you see it at a later date. You will receive it only if you attend it for all 3 days and attempt post-test and where you have to score more than 15%. So once again, congratulations to the entire team and of course my ICOG staff who is also working very hard, helping in all aspects of this program. I think with this we'll conclude today's session and
Yes.
we'll meet tomorrow at 4 o'clock sharp for the second day.
Thank you so much, Parag, and I'm very happy to share with you that there were 900 plus registrations and 600 delegates all the time here. So thank you. And we are very happy to share with you that within a span of 3 weeks, we could, arrange this program and could bring it to the, fact. Thank you so much.
Okay. See you all tomorrow.
Thank you.
Thank you, ma'am, for an opportunity, and thank you all the faculties for joining in today.
Thank you so much, Monica, for wonderful coordination as well. Thank you. Thank you so much, the ICOG office team as well. Thank you, my dear
Sneha.
friends.
Well conducted program.
Madam.
Parag and you have done a wonderful job. All the program is very good and all the speakers are excellent. Thank you very
madam. Thank you, madam.
Thank you, ma'am.
So much.
It was excellent program, Dr. Sneha, Dr. Parag. Congratulations and thanks for making me part of this. Thank you so much.
Thank you, dear. Thank you so much. And thank you, everyone. Bye-bye. See you all tomorrow.
Bye.